Bonsoir tout le monde. Everyone, welcome to this meeting of the Special Committee, Joint Committee on Medical Assistance in Dying. I'd like to begin by welcoming members of the committee, witnesses, as well as those watching this meeting on the web. My name is Mark Garneau, and I am the House of Commons Joint Chair of this committee. I am joined by the Honourable Yonah Martin, the Senate's Joint Chair. Today we are continuing our examination of the statutory review of the provisions of the Criminal Code relating to medical assistance in dying and their application. Vous connaissez tous les...
You are all aware of the directives of the Board of Internal Economy regarding health protocols, so I won't reiterate them now. I hope that you will uphold all of them. I'd also like to remind members and witnesses of the importance of muting their microphones at all times unless acknowledged or recognised by the chairperson. I'd remind you that all remarks must be made via the chairperson or chairpersons. Please speak slowly and clearly. Interpretation services provided for this meeting are the same offered by in-person meetings. At the bottom of your screen, you can choose between the floor, English or French.
Quick committee business. On Wednesday, April the 20th, the Subcommittee on Agenda and Procedure met to consider committee business and has made some recommendations. Pursuant to House of Commons procedure, the committee must ratify the subcommittee recommendations to put them in force. Those recommendations were: 1, hearings are divided into 3 one-hour panels. 2, written briefs must be received by 9th of May and not exceed 1,000 words. 3, today's testimony is from practitioners and family members, and the next meeting theme will be palliative care. And 4, themes that we will be dealing with during this committee's meetings are in the following order: palliative care, advanced directives, disabilities, mature minors, and mental health, in that order, as I said. The clerks have distributed Report 1 of the Subcommittee on Agenda and Procedure. Do members have any changes they wish to propose to the report, or are they ready to endorse it? Does anybody want to make a change? I don't see anything, so is it the pleasure of the committee to adopt the report? I see unanimity. With that, I would like to welcome our witnesses for panel number 1 and turn it over to Senator Yonah Martin. Senator.
Thank you, Mr. Garneau. I'd like to welcome our witnesses and introduce them first. As an individual, Dr. Felix Pajot, geriatrician, ethicist, and researcher, Université Laval. From the Canadian Association of MAID Assessors and Providers, Dr. Stephanie Green, President, MAID Practitioner, Advisor to BC Ministry of Health. And thirdly, from the Canadian Nurses Association, Tim Guest, Chief Executive Officer, and Barbara Pessu, Principal Research Chair, Palliative and End-of-Life Care, University of British Columbia, Okanagan. I'd like to make a few comments to the benefit of our witnesses. Before speaking, please wait until I recognize you by name. A reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. Interpretation in this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. And when you are not speaking, please keep your microphone on mute. With that, I'd like to welcome our witnesses for this panel. You each have 5 minutes. And we'll begin.
Mr. Chairperson, on a point of order, the sound in the room the volume is far too high, such that I can understand the French simultaneous interpretation. If the volumes could please be adjusted, that would be much appreciated.
Madam Co-Chair, somebody has said that we need to make an adjustment to the volume of the voices for those in virtual. So if we could suspend for a minute, we'll try to adjust that.
Thank you. Thank you. And we'll have our first presentation, Dr. Felix Pajot, for 5 minutes, please.
Bonjour, merci.
Good evening. Thank you for this opportunity to speak. I'd like to give you the broad brushstrokes of my presentation. Canadian and Quebec organisations suggest that medical assistance in dying for people with major neurocognitive disorders could reduce suffering. It is also assumed that dementia can be seen as a horrible affliction, and this would be the view of majority of Canadians and Quebecers. Those who fear being cognitively impaired will go so far as to wish for their own death. In this short brief, we will show you why it is unethical to allow medical assistance in dying in dementia by way of advanced medical directives. My argument is threefold. It's practical, it's emotional, and is underpinned by the principle of autonomy in context. Practicality. In Canadian healthcare, there remains a significant shortage of geriatricians. Although many family physicians assess dementia and its consequences, it seems an expert eye is needed to determine the level of suffering of a person with advanced dementia. It is very difficult to predict the course of a cognitive disease with certainty. Few reliable criteria exist for judging pain, mood impairment, and existential suffering. Often, when no reliable tool exists in the clinic, expert opinion is sought. For advanced dementia, there are a few such experts, i.e. geriatricians, geriatric psychiatrists and physicians who work in long-term care facilities. There are very few of these specialists in Canada. Also, in the Netherlands, the only country where euthanasia by advance request is permitted, the majority of these medical experts do not follow advanced medical directives. The latter are often not clear enough or even inconsistent with what exists in reality in care. Thus, in practice, MAID by AMD is not applicable in Canada because of the lack of specialists to evaluate people with dementia who wish to have MAID. Also, when access to euthanasia by AMD is allowed, as in the Netherlands, it is very rarely applicable. Furthermore, in Quebec, a group of researchers noted that Quebecers in their study did not really understand what advanced medical directives were. This is not the strongest ethical argument, however. The number of geriatricians, geriatric psychiatrists and physicians in long-term care facilities could be significantly increased. This would be quite a challenge, but it is not impossible in absolute terms. With more research in gerontology, we could come up with reliable scales for assessing physical, psychological and existential suffering in advanced dementia. However, this research must be adequately funded. Finally, guided by their physician to fill out their advanced medical directive, patients could write directives that make sense according to clinical reality. It is therefore important to analyse other emotional and ethical arguments in advanced dementia. Fear of decay. Dementia causes loss of functional autonomy. This means that it causes difficulties in performing domestic and daily tasks. We understand that people are afraid of becoming demented with the experience that they might have in long-term care facilities and nursing homes because of the COVID-19 pandemic. This fear is only partially justified. There has been a lack of care, but geriatric services still need to be improved. More caregivers, i.e. nurses and orderlies, can be trained and hired in Canada. Also, valuing the work of family caregivers and adding resources of all kinds will be essential. Beyond the strong desire to improve geriatric care in Canada, other interventions will be needed to reduce the fear of quote-unquote decline or decay related to cognitive loss. We also need to combat the prevailing ageism, which refers to the discrimination of older people through malicious attitudes, derogatory behaviours and conduct, and hurtful words. Ageism is pervasive in the medical profession and is in the prevailing culture in the West and leads to elder abuse. One of these is in advanced dementia, in our view. The elderly person in vulnerable situation because of cognitive disorders is often no longer considered a full citizen since he or she does not work and is not profitable to society. This is the liberal economic vision of the human person, which defines the value of an individual by his or her ability to work, and that is wrong. It leads to discrimination and even hatred of people with dementia. It is assumed that there is a decline because the individual has disabilities, mental illnesses, and cognitive impairment, all related to dementia. As Canadians, we should be advocates for vulnerable seniors. In my professional experience, older people may even need to be convinced that they still have value despite their cognitive deficits or psychiatric illnesses. Indeed, older people can internalize this self-hatred. What I mean by internalize is a concept that is well known for other forms of discrimination. The person who frequently hears derogatory remarks about himself or herself will come to believe that these supposed flaws or problems are real. The same is true of ageism. Even though they should defend themselves, the person comes to accept and even believe the negative prejudice against them to the point of seeking MAID. However, it is important to recognize.
Yes, thank you. We have a time limit of 5 minutes, so you went a little bit over, so I'll ask the next speakers, and I'll try and give a 30-second warning. So next we have Dr. Stephanie Green.
Great. Thank you to the committee for the opportunity to speak with you today. I'm here as the president of the Canadian Association of MAID Assessors and Providers, the clinical subject matter experts on MAID in Canada, and as an experienced practitioner. As my remarks must be limited, I will not dwell on the elements of implementation that have proven both important and well done. Rather, these are fleshed out in my written brief. But I will highlight the most important, and am willing to discuss further if you wish. The fact that we allow clinician-administered MAID, that MAID is not restricted to terminal illness or imminent death, and that we simultaneously provide very good access to palliative care are all essential to high-quality care for Canadians. I note that Bill C-7 fixed the unconstitutionality of requiring a reasonably foreseeable natural death, removed the problem-causing 10-day waiting period, and added an important waiver of final consent. Data to date suggests the expected number of Canadians are accessing and receiving MAID, and that those who proceed with MAID are disproportionately advantaged versus socioeconomically vulnerable. Well done. Through my work, I have seen evidence of the distinction between what others might hope to conflate, MAID and suicide. Suicide is almost always a traumatic event, often violent, frequently impulsive, usually carried out alone or in secrecy, and it leaves devastation in its wake for families, for first responders, often entire communities. By contrast, medical assistance in dying involves a legal framework, a rigorous process, the involvement of multiple healthcare practitioners, and the option to involve many loved ones. I've witnessed the therapeutic effects of merely telling someone they are eligible for an assisted death, and have seen people live longer than they thought they'd be able to because they had this option. As a colleague so eloquently once stated, suicide implies some form of self-destruction. Assisted dying, a form of self-preservation. They're simply not the same. This work was especially challenging in the beginning. No training, no guidance documents or standards. CAMAP and early practitioners filled that void, and while tremendously proud of all we've accomplished, I quote a colleague from just a few days ago lamenting the lack of practitioners in her region, saying, "The feds need to work with medical and nursing training programs, as well as provincial ministries of health, to address the limited provider assessor issue, or these changes will be meaningless." We couldn't agree more. Please read my brief for a review of the factors at play. The establishment of a two-track system of access to MAID has led some practitioners to withdraw their services due to both a perceived and real complexity in process as well as patient population. CAMAP's federally funded Canadian MAID curriculum project is an important positive step towards helping correct the significant lack of standardization of care across the country. It will help set a standard of practice and should provide both clinicians and the public some measure of confidence. But a lack of accessible expertise and/or resources for patients continues to hamper practical efforts. Clinicians have begun to experience distress when faced with people who are eligible for MAID, but whose suffering is primarily due to a lack of appropriate resources. We are not in any way suggesting MAID be curtailed due to the failings of our society, but are strenuously suggesting that MAID and community resources for mental health, palliative care, and disability supports be developed and supported in parallel. With my background in family medicine, I have seen the torment of families who are faced with the unbearable, the birth of a non-viable child, or one with terminal illness, and I have journeyed with them. Mature minors in Canada already make their own healthcare decisions in the denial or acceptance of blood products or with regard to reproductive health choices as examples. We already have experience in assessing their capacity to make independent decisions. In the catastrophic circumstance of a mature minor with an illness that is causing unbearable suffering, who in very rare cases might ask for access to MAID, to discriminate on the arbitrary basis of age seems indefensible and in fact blatantly cruel. Despite an initial discomfort, you might find a safeguarded allowance of MAID for mature minors the most clear-cut of all the issues that you are considering. I will leave the discussion of advance requests to others except to note that its lack of availability is the concern that I hear about at every presentation I have ever given on the topic of MAID. We would urge this committee to undertake a comprehensive review of past and current reports and recommendations, seek input from frontline clinicians, and make a decision about a matter that the majority of Canadians wish to see resolved. My final message: it remains unclear who or what is responsible for access issues, the federal law or the provincial taxpayer-funded yet objecting facilities. And as clinicians charged with doing this work, we are still far too few. Help train us, compensate us, and adequately resource our communities, or we will be unable to help people in the way that you...
Madam Co-Chair, Mr. Co-Chair, and members of the committee. We are pleased to be invited to share with you the perspective of nurses on this important study. I'm speaking to you today from Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq. My name is Tim Guest, and I'm a registered nurse and the Chief Executive Officer of the Canadian Nurses Association. I'm joined today by Dr. Barbara Pessett, a registered nurse and a Principal Research Chair in Palliative and End-of-Life Care at the University of British Columbia. CNA is the national and global professional voice of Canadian nursing, and we represent nurses across all 13 provinces and territories. Canada's 440,000 nurses touch the lives of patients at every point of care, and no provider has as much direct interaction with the public where complex human issues arise, such as medical assistance in dying. Nurses have acquired significant knowledge and experience from nearly 6 years of MAID in practice and have valuable knowledge to share. In fact, nurses are the most consulted healthcare professionals when MAID practitioners are seeking to inform their assessments. Today, I will share key findings from a study conducted from Dr. Pessett on nurses' experiences with MAID, as well as some preliminary highlights of consultations conducted by CNA with nurses. In 2017, Dr. Pessett and her team began a 3-year study of Canadian nurses' experiences with MAID. The 59 nurses that were interviewed had diverse opinions about MAID, informed by different levels of engagement with cases. The study highlights how there is great variability in how MAID has been enacted in nurses' workplaces. Nurses emphasized the importance of teamwork in providing high-quality MAID care, although many worked without the benefit of a team. Nursing work related to MAID is highly complex because of the need for patient-centered care in systems that were not always designed to support such care. Without adequate supports, some nurses chose to limit their involvement in MAID. The study concludes that without accessible palliative care, sufficient providers, a supportive team, practice supports, and a context that allowed nurses to have a range of responses to MAID, nurses felt they were legally and morally at risk. For its part, CNA held consultations in 2020 and in 2021 in partnership with the Canadian Protective Nurses Society, with nurses involved in MAID, which provided insightful learnings of their experience and their expert opinion on MAID overall and the 3 special populations of mental illness as a sole diagnosis, mature minors, and advanced requests. Nurses highlighted the lack of access to palliative care in Canada and the importance of scaling it up, as well as other types of services to ensure patients are not opting for MAID due to the lack of access to acceptable alternatives. For example, we heard that limited access to primary care in rural and remote settings has led to patients directly reaching out to urban centers for MAID services. Furthermore, nurses stressed the need to put in place strong safeguards to ensure appropriate use of MAID for the 3 special population groups if MAID is expanded. We also heard that practitioners with appropriate expertise within these 3 groups need to be involved in the MAID process, although we recognize this also brings concerns of creating barriers and limiting access. Finally, we urge that if changes to the criminal code are brought forward, it is done in a way where safeguards and provisions are clear and include objective criteria. We need to ensure the practitioners can confidently interpret and implement the criminal code provisions. In conclusion, the practice of nursing has been profoundly affected by the availability of MAID in Canada and the moral ambiguities it creates within the world of clinical practice. CNA heard from nurses that MAID can have an emotional toll on clinicians who are providing it, particularly in areas with scarce resources and lack of important alternative treatments, such as palliative care. Thank you, and we'll be happy to answer any questions.
Thank you, and thank you to all of our witnesses. We'll go right into round 1, starting with Mr. Cooper for 5 minutes, and I'll give a 30-second warning.
Thank you, Madam Co-Chair, and thank you to the witnesses. I'm going to direct my questions to Dr. Pajot. Dr. Pajot, the Supreme Court of Canada stated unequivocally 3 times in Carter that medical assistance in dying may only be performed when a patient clearly consents. You spoke about advance directives. In the face of the pronouncement of the Supreme Court, do you believe that an advance directive can be a true expression of free and informed consent consistent with Carter?
Merci pour la question.
Thank you very much for the question. It was the last part of my brief that I didn't have time to read due to a bit of stress, but autonomy must be exercised in context. We need the context to know what the context is, the environment, the health context, and that's why I called on you 3 years ago to make decisions about what should be done to deal with the pandemic and what would have happened in long-term care facilities. And had that happened, you may not have made the same decisions as you had. So autonomy must be taken in context. Right now, we're not talking about an exercise of autonomy. Although this seems like autonomy, in fact, they are being guided to this decision through loved ones who are trying to be caring and kind to the patient. So that's not real autonomy in the context of MAID. This autonomy isn't being exercised in context, but only at the time of the decision. And one doesn't know what's going to happen in the future. No one can predict what's going to happen in the future, especially if you have dementia or a cognitive disorder. And the context may change, especially when it comes to geriatric care. And we've seen this over recent years. We knew that there were problems in long-term care facilities, but the pandemic has shown the extent of these problems to the public. If you'd made this decision 5 or 6 years ago, would it have changed? Well, of course, the context changes with dementia. dementia changes the life not only of the person who has dementia, but all their loved ones. It's no longer the same person in a sense. They have changed so much and they're not really exercising autonomy per se. So it's very risky to permit MAID in a situation when you're not really being autonomous and really you're handing over your decision-making faculties to caregivers, and therefore it should not be permitted in that context. It's a big mistake. I referred to ableism and ageism in my brief, and also discrimination and stigmatization of mental health issues. So dementia use of MAID is really complicated because of all the other issues that are comorbidities and other issues that are internalized by the individual. So everything needs to be taken in context, and it's very risky to include MAID in advanced medical directives because there might be a whole lot of conflicts of interest, for example, freeing up beds in emergency.
So I'm sorry to interrupt, but my time is limited, and I'll let you continue on in your answer. But when you speak about context, if you can speak in context to dementia, and more specifically, whether there are elements for someone who is suffering from dementia that are impossible to predict in the context of an advanced directive. I think you were talking about that, but if you can elaborate a little bit about that, as well as I was interested in you mentioning the experience in the Netherlands, which is the only jurisdiction, as I understand it, that has advance directives, or one of the few, and the fact that in very few instances were those advance directives being carried out in accordance with the wishes of the patient when the advance directive was drawn. Can you speak to those issues?
20 seconds.
Well, most times advanced medical directives are difficult to fulfill given the decision has been made in that context. So often requests are made by the families themselves. And there was a study conducted by Ariane Plaisance in Quebec that demonstrates that people don't really know what advanced medical directives are or MAID is, and that's often confused with palliative care writ large. So often when they're asked if they want MAID, they think that they mean palliative care.
Thank you. And next we have Mr. Maloney for 5 minutes.
Thank you, Madam Chair, and thank you to our witnesses. I'm going to start with Dr. Green. Dr. Green, I think I saw you recently on the Fifth Estate talking about MAID. I was interested in some of your comments there. I'm going to pick up on something you mentioned in your opening remarks, and that is talking about mental health issues. You distinguished between suicide and MAID. I take it that you're very clearly in the camp of allowing MAID for people who have mental health issues?
I'm just going to say you shouldn't make assumptions, so I'll take the question if you want me to answer that first.
Yeah, please. And I didn't mean to assume. My interpretation was wrong. Then please straighten me out.
Yeah, no, I think certainly as a representation of CAMAP, I'm always careful. Our organization does not advocate for MAID or in any particular patient population. We advocate the highest level of care under the current law. So if our law is to allow mental health patients to access MAID in 2023, then we will do our very best to accommodate that with the recommendations of the expert panel, and we look forward to that. So I don't know that my preference or my beliefs are of import, really.
But your opinion is, Doctor, and I'm curious to know whether you think the legislation that's coming into force in 2023 is correct. Like, should we allow MAID for people with mental health disorders, in your opinion?
Well, to be honest, I think it's a legal question. I think that it's discriminatory to tell people they're not allowed to have access to MAID based on a diagnosis. So I understand that decision. I'm in favor of following the decision of the House of Commons and the Senate, and I'll do my best to provide the highest level of care for those patients. Well, certainly, I'm not going to withdraw my services because of that.
Okay, thank you, Doctor, and I respect that, but I'm a lawyer, so I will follow the law too, but I often rely on the advice of medical practitioners in determining what's right and what's wrong, and I think that's why we're here. So you are somebody who has extensive experience in this. I think it's a fair question to ask you whether you would be supportive of the law that's coming into force in 2023 or not. If you're not comfortable asking that question, I'll move on.
No, I'm comfortable saying that I'm comfortable to provide MAID to mental health patients who fulfill the criteria of the law. Absolutely.
Okay.
I would not withdraw my services there. Yeah.
Here's my concern when it comes to mental health. I have some experience dealing with doctors. If you show 10 doctors an X-ray or a CAT scan of somebody who's got cancer, all of them will agree that the person has cancer. If you have 10 people who are examining somebody with a mental health problem, there's a chance that 2 or 3 of them will reach the conclusion that the person does not have a mental health problem. Does that analysis cause you concern, or should it cause me concern, in your opinion?
To be honest, I think that when mental health patients start to step forward for this care, we're going to have to be very, very careful with how we assess them. I think that it's valid to think we're going to need more expertise. We're going to need more consultations. We're going to need to be very careful and maybe different than what we're doing right now. But I do actually have faith in the physician and nurse practitioner community to do their jobs properly. I think we can assess capacity. I think we can assess whether they have a diagnosis or not. I think we can assess suffering. I think we've done that before there was MAID. I think we do that now that there is assisted dying. I think that we'll be able to do that in that population. I'm confident we'll be able to do so.
As well, but in the off chance that somebody's wrong, we're talking about the most dire of consequences here. So let me move on to mature minors, because I have the same concern there, because it requires a subjective assessment by a doctor or doctors to determine whether somebody is in fact mature enough to make a decision. You use the example of making decisions on reproductive health. Do you agree that you run into the same problem with making an assessment about whether somebody is mature enough to make that decision?
No, I would disagree with that. I think we have lots of experience determining whether minors have or do not have capacity to make their own decisions. We've been doing that for decades. We certainly have experience in reproductive health choices, in blood products, and lots of different circumstances. I think that we are very, although it's always tricky, I think we have experience and have shown that that can be done safely and carefully. So I think that can absolutely be done. And I don't think it's subjective. I think it can be objectively determined.
Thank you, Doctor. I'm out of time. Your comfort gives me some comfort, so I appreciate your answers. Thank you.
Thank you.
Thank you. And next we have Monsieur Theriault, 5 minutes.
Merci.
Thank you very much, Madam Co-Chair. To begin with, I think to facilitate the work of the committee, we should agree on the use of terms. Currently, the term AMD is being used as if we mean a request for MAID, whereas advanced medical directives are not an issue. This is part of normal medical practice when it comes to the refusal or termination of treatment. So if we continue to conflate the terminology between a request for MAID and AMDs, well, we won't be able to get a handle on this issue conceptually. So I think we need to agree. Mr. Pajot, now, in your defence, you didn't have much time to shed light on your innermost thoughts. But based on what I heard from you, and I understand that one needs to be very careful of falling into traps like ageism, but you seem to think that in order to facilitate access to MAID, that the government would proceed by way of a lens of benevolence when it comes to hindering the autonomy of someone and their ability to have self-determination. Well, that, in fact, is a breach of their dignity and has nothing to do, and you mentioned this in other articles that you wrote, that death is not beautiful at all. In fact, it smells, it has an odor about it, and that really, but by definition, the medical profession and healthcare professionals have to be benevolent. If they are malicious, well, then they will face the consequences and ramifications. So as a government, you can't be benevolent if you are breaching the autonomy of someone. So if you are afflicted with dementia, how can the state take away your definition of what tolerable is? How is that ethical in any way? Well, you're right, sir. Autonomy, dignity, human value, these are all different concepts. Yes, autonomy is a rational capacity to have self-determination, but benevolence isn't directly linked with autonomy. Some authors think that it's benevolent to respect people's autonomy. Others believe it's benevolent not to respect their autonomy. And these two points of view come into conflict. Yes, sometimes you can do good by taking away someone's autonomy, but in dementia, the crucial point is that these people no longer have autonomy. And when it comes to AMDs that provide a prior decision, well, yes, it's a way of presenting autonomy in the future, but unfortunately that autonomy can't be properly exercised because the person isn't aware of what is occurring. So this isn't true benevolence. And the government is preventing people afflicted with dementia from enjoying real benevolence. So my argument is that if we do permit MAID, well, we may risk a prevailing view that these people will no longer have value. And unfortunately, you know, we clean these people, we look after them, and that is a benevolent care. But because they no longer have autonomy. I'm sorry to cut you off, sir. I'm sorry to cut you off. But how does this state's prohibition, how would it be more worthy and more dignified? How can the state say to a person who knows their mind, who knows what their diagnosis is, and who decides that with a benevolent, caring professional healthcare team, when I will have reached X, Y, or Z state, I will have gone past my threshold of tolerance, and because I'll be no longer capable of being competent, I would like you to proceed in this manner. How is that ethically improper? Response: well, there's a logical issue here. When you reach that stage, you no longer have autonomy. It's just the choices of others and their benevolence that are foisted upon a person afflicted with dementia. But how can the state, what would be the value of the state?
Thank you. I'm going to go on to Mr. McGregor. 5 minutes.
Thank you very much, Madam Co-Chair. Dr. Green, I'd like to start with you. In the motion that the House passed authorizing this committee to start its work, one of our main topics is going to be the protection of Canadians with disabilities. And you know, I was furiously scribbling notes as you were making your opening statement, and I do know that you made reference to the necessity of disability supports. I have heard concerns, and I'm sure many of my colleagues have, from commentators who have said that MAID could be requested by vulnerable populations because of a lack of supports to ensure an adequate quality of life for individuals who may be sick or have a disability. With that in mind, those concerns that have been expressed, I'd like to ask you, in your practice or in that of any of your colleagues, can you talk about any encounters with individuals who have sought MAID, whose requests seem to be based on a lack of supports? And if so, how did you or your colleagues advise those individuals?
Yeah, so I won't talk about so I won't talk about any in particular cases because there are still very low numbers of people from the Track 2 coming forward, and even less in the circumstance that you describe, though I'm sure it's not zero. I think what we are starting to see, as I mentioned, are people who are coming forward who have expressed that their suffering is extreme and intolerable, and the feeling of the clinician involved is that perhaps improved resources might alter that, might improve and lessen their suffering if it were available. That's not necessarily coming from the patient. It may be that they've expressed they haven't been able to access something, but it's coming from the people who are doing the work, the assessments, and who are noticing that maybe this patient hasn't had access to, we'll say, a pain specialist because they live somewhere rurally where there is no pain specialist. And so the interesting dilemma is, what do we do in a situation where someone truly meets the criteria of eligibility for MAID, but the clinician believes that maybe something more could be offered, but it's not actually reasonably available to that patient. And that's causing distress in some of my colleagues, and we are not moving those cases forward. But we do ask that the government federally and provincially help fix that situation, help make more robust the resources that can be made available. We can't fix the healthcare system as clinicians necessarily, and we certainly do not suggest that we curtail MAID in general, but we do think that you cannot hold individuals hostage to society's failings and the healthcare system's failings. That's just not fair. That is why we support the parallel development of resources and adequate resources at the same time that MAID is being developed and supported.
And, do you think the trend could increase? I mean, I guess in your mind, what kind of a gap do you think the federal and provincial governments are looking at, trying to properly address so that, you and your colleagues no longer need to worry about those additional situations in a person's life, so that you can focus solely on the clinical aspects of a person's case?
I wouldn't presume to be able to answer that. I think it's been just a year since we've had these patients coming forward, and there's very few of them. So I think, ideologically, I can tell you I've been in the healthcare system for several decades, and there are many gaps in our healthcare system. I don't think we need MAID to point that out. So I imagine the gaps are substantial in some areas and minimal in others. I think it's too soon for me to be able to answer that from the perspective that you'd like.
Appreciate that. Thank you. In the final minute that I have, maybe Mr. Guest, I'll turn to you from the perspective of the Canadian Nurses Association. If you wanted to add a little bit more about your experiences about the issues of accessing MAID in rural, remote, and northern communities, and, in your mind, how that access can be improved, is there anything you wanted to add in your testimony to our committee?
About 35 seconds.
Thank you for the question. Based on our consultation with nurses, some of what is concerning is that there's a lack of equity in accessing individuals that are participating as assessors or providers for those services. And the other thing that we've also run into when we've had conversations with nurses that work in those areas is concerns that individuals may choose to access those services maybe sooner than normal because they're unable to access other services that would enable them to delay those decisions.
Thank you. We'll go into the questions for senators. So, Mr. Co-Chair, I will turn this back to you.
Thank you, Senator. And nous allons continuer la ronde.
We'll now continue with senators, and we'll start with Senator Mégy. Senator, the floor is yours for 3 minutes. Please proceed. Thank you very much, Mr. Chairperson, and thank you to the witnesses for appearing today. Dr. Pajot, do you practice MAID yourself? Response: no, I do not practice MAID. Question: what would you say to an individual of 55 years of age who looked after their parents through the process of dementia right up until the end stage, and then at that point they say, I don't want to end up like that, and I'm going to decide right now that from the point when I will be in this situation, I would like to have MAID. If someone confides in you in that way, would you try and deter them? What would you say to them? Response. That's an interesting question. I discussed the matter with a nurse today who looks after people with dementia, and her argument was that she doesn't want to become reliant of those medical professionals in long-term care facilities who are not kind, who do not provide the kind of care that she would like to receive because she's had that experience. Now, has anyone confided in me? I don't know anyone who's 55, but if someone who's 65 made that request, well, we often see these requests from the children of our patients. Oftentimes, they have looked after their loved ones for a long period. They become very tired. They see it as a burden. They don't want to impose the same burden on their families. I understand that. This burden requires a lot of specialised resources. There's various types of dementia, some that require less specialised care than others, but then there are psychological and behavioural issues that requires highly specialised care from highly specialised individuals. And these patients' children project and they say to themselves, I don't want to live like this. And that was what I referred to earlier, this fear of the decay from dementia. They've internalized this ageist belief that I don't want to be disabled in Canadian society. I don't want to be a burden on Canadian society. I don't want to be mentally ill in today's Canadian society because it is so highly stigmatized. And often there's a lot of contempt for people with mental health issues. But in my personal experience, they can get very good care and improve and no longer be seen as a burden to their families. And therefore, spouses, children, loved ones can really become caregivers rather than having to bear this unbearable burden. I understand that fear, I understand that desire, but as I said earlier, we need to get improved geriatric and palliative care in Canada in order to allay this fear of decay and decline that we hear so much about. Thank you very much.
Senator Kutcher, you have 3 minutes.
Thank you very much, Mr. Chair, and thank you to the witnesses. My question is for Dr. Green. We understand that your organization is working to create a national MAID assessment and intervention program that will have the impact of standardizing MAID delivery across Canada, and additionally, through the process of certification, create comprehensive and high-quality standards for health providers who deliver MAID. Could you please tell us more about this work, including what organizations are involved, who is providing the certification, what will the certification achieve, and do you think that this outcome will, over time, create a recognition for MAID provision similar to that which has been recently developed and is now available for palliative care provision?
Thanks for the question. CAMAP is particularly proud of our development of this particular program. This is a national program which is federally funded by Health Canada. It's a multi-year program that is meant to help people, clinicians who are new to the field, as well as those who are already in the field looking to expand their skills. This is a very large program with I think our team kickoff included about 90 invitations. There are currently from the ground up 8 working groups that are diverse from a geographical point of view, from a medical and nursing background point of view, from an EDI lens. They are each working on a module which will contribute to the overall curriculum. These working groups are accountable to an executive committee of leaders of each of those working groups that is then overseen by both the CAMAP board, but more importantly, perhaps a national stakeholder committee, which is made up of 17 different national member organizations, each of which is a significant stakeholder in MAID in this country. This includes, and I will not name all 16 of them for you, but this includes the Royal College of Canada, the Canadian Family Practitioners Association, the CNA, Rural Physicians, Indigenous Representation, Palliative Care, psychiatry, the Collège de Médecins du Québec, quite a diverse group, so quite a bit of oversight. We have a project team of 3 full-time staff. Again, this is a project that will last till 2025. At the end, we will have 7 modules that are both online, offline, synchronous, asynchronous, bilingual, easily accessible, fully accredited by the national organizations, including the family practitioners, the Royal College, and the Nursing Association, who have already committed to helping us achieve that proper accreditation. We are not looking at credentialing. We will not be applying letters after the names of the people who complete this course, but they will, in fact, be able to point to this curriculum to say they have completed it. And we hope that that will, in fact, help with the standardization issue across the country, which is significant at this point, and to help build confidence in both the clinicians and the public. I hope I've answered your question.
Thank you very much. We'll now go au prochain sénateur.
The following senator, Senator Dalphond, you have 3 minutes. Thank you very much, Mr. Co-Chair. My question is for Dr. Pajot. Dr. Pajot, I understand that you work in geriatrics, clients of my age, for example. Now, when an individual has written or issued advanced medical directives and that they're no longer able to make a decision for themselves, well, then this is substituted consent. The doctor will speak with the family. Do you refuse to speak with families? Do you refuse to make good on advanced medical directives? Response: no. Currently, the advanced directives are legally binding and I have to adhere to them because I follow the law. But that comes back to my point that this is a major issue when it comes to advanced directives. There is no autonomy when it comes to advanced directives, when it comes to euthanasia. Any document that forces medical professionals to provide this care, well, MAID is considered MAID is considered obligatory. One is forcing the physician to take particular action, and I'm not comfortable with that. Often these individuals don't understand fully what MAID is. They don't understand what advanced medical directives are, and the experience in the Netherlands attests to this. Often these directives are not reliable because sometimes these individuals didn't really understand what they are experiencing. And the individual thinks that because they've written something down in advance, that might be reliable and applicable. But unfortunately, when faced with the real situation in context, one realizes that those advanced medical directives aren't necessarily achievable, and that is my greatest fear. And that's why I'm uncomfortable to end a vulnerable person's life when they have dementia, because they haven't really taken an informed decision. And they're asked to sign a document which really isn't reliable. I think to end someone's life, one needs to be really certain. And when I said I don't exercise MAID, well, in that case, do you refuse? Well, I don't take issue with death in and of itself, or terminating care, or not proceeding with futile care, for example. My problem is proceeding with what I call passive euthanasia, that is helping people to go through with a death when their autonomy has been impinged upon. Now, I understand that for someone with dementia, when it's advanced, when they no longer enjoy autonomy, well, it's a different kettle of fish altogether. And as I said, there is a huge risk of taking improper decisions. We've seen this in the Netherlands. A woman who had dementia who was forced into euthanasia. I'm sorry, I'm going to have to cut you off.
Mr. Walden, you have 3 minutes.
Sorry, I think there was crosstalk there, but if you're asking me to go ahead, I will. Thank you. I'm wondering if, just before I ask my questions, whether Mr. Pajot would provide any evidence from the Netherlands about cases where people have been forced against their will to, I think you said, to sign documents. People aren't generally asked to sign documents. They actually have the right to choose it or request it. So if you've got specific examples of that and that it constitutes evidence, I'd like to hear it. My question is for Dr. Green. As we've heard from our witnesses earlier, of course, no one can predict the future. But we do this all the time in healthcare. We opt to have surgery when we may not know the outcome. We opt for do not resuscitate orders in the case of future accidents or conditions that may arise, and we don't know what the details are, but we ask for that. In the case of cognitive decline, we know the outcomes are inevitable. There is a resulting physical decline. We know that's inevitable. And what's harder to deal with this fear of decline and the fear of being denied the right to have any choice or any control over your health outcomes, which we respect in these other cases. Are you concerned that in fact, can hasten the decline of cognitive status and physical status in some? And secondly, and there are cases of this that I'm aware of, some people then choose to end their lives earlier because they fear that inability to make a choice or be allowed a choice later on.
Yeah, thanks for the question. There's a couple parts. If I forget some, please remind me. I do think that we've had precedents, we've had experience in the past 5 years before the amendments where we've seen patients who were nearing the end of their death and were really, really fearful of losing the capacity to make the choice to go ahead with assisted dying. That was causing tremendous anxiety in patients and their families, to the point that we were able to give that feedback to the government, and they heard that story and created the waiver of final consent for very specific populations, so that they would take their medications, their pain medications at the end of life. They would not withhold that from themselves in fear of losing capacity. So I think there is evidence of patients making premature choices out of fear of what's to come, or fear of loss of ability to make those choices, or fear of losing control. We've heard lots of talk today about advanced directives, and I think it's very, very well established in medicine for decades now that patients do have the right to give an advance directive for their care in situations that they may not fully understand at the time, such that if they were found to be on life-sustaining medication, to be ventilated, they might choose to have that removed. And they can make that choice now clearly in a document which we all agree must be respected. So I think we have good precedent for advanced directives of some sort. And we do have...
Thank you. We'll go to the last senator. Senator Martin, you have 3 minutes.
Yes, thank you. My question is for Dr. Pajot. I'm that 57-year-old who had a mother with dementia for 12 years, and she had palliative care for only sort of less than 2 weeks. So I saw a very, very, when I say positive, I just saw my mother live her life to the fullest, to the best of her ability. And so had she not done that, I know that out of my fear, if an advance directive or discussion of advance directive of MAID were given to me, I may choose to have such a directive because of this very, terrifying experience with my mother. So would you speak a little bit more about the importance of the timing, and should directives and MAID, like when should it be discussed? Because I could see as a 57-year-old what I may have chosen had my experience been different. Dr. Pajot.
Oui.
Well, I don't know if I should speak to the previous issue of data, but in my brief, I referred to the Canadian Council that reviewed the literature of cases in Netherlands. So you can refer to my brief, but as far as dementia is concerned, it's extremely sad to consider that MAID would have been the case for your mother. And that's the point that I'm trying to make here, that death is better than palliative or geriatric care that we have in Canada. That's an extremely sad state of affairs. In the debate, one hears that instead of opting for healthcare, there's a preference for MAID or active euthanasia as is being practiced, or assisted suicide. So that's a very sad state of affairs, and I understand that you're sad about this. Oftentimes, what I hear from families of patients, whether they be biological families or adopted families, those who look after seniors in a system that is ageist in and of itself, that doesn't act in the best interests and in a benevolent way towards patients. There's unfortunately a lot of institutional malevolence. And that's very sad. And MAID seems to be a solution, but in my opinion, that's not the correct solution. Palliative care is.
Seconds.
Thank you. We'll go to the second round for the members. So I'll call on Mr. Cooper once again for 3 minutes.
Co-chair, we're going to have to proceed to the second panel at this point. We've had our we've done our 1 hour. Yes.
I see. All right. So
I can just wrap it up by saying thank you very much to our witnesses. Thank you for your input this evening. Thank you for answering our questions. C'est très apprécié.
Was highly appreciated, and what your input is very important in the work that this committee is going to continue to do over the upcoming weeks. Thank you for coming.
Would like to suspend very briefly as we transition to panel number 2. Through joint chairs. When speaking, please speak slowly and clearly to allow for translation. Interpretation of this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. And when you are not speaking, please mute your microphone. With that, I'd like to welcome our witnesses for panel number 2, Dr. Leonie Herx, Chair and Associate Professor, Palliative Medicine, Queen's University, and Chair, Royal College Specialty Committee in Palliative Medicine, ainsi que le Dr. Alain.
As well as Dr. Alain No.
Alors, merci à vous deux.
Thank you to both of you for joining us here this evening. as panelists, and we'll start with remarks from each of you, 5 minutes length.
For your introductory remarks, Doctor, you have 5 minutes.
Sorry, I can go ahead?
Yes, please.
Good evening. Thank you for the opportunity to speak on palliative care as it relates to the statutory review of Canada's current medical assistance in dying legislation. I am speaking to you today as a settler on the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation. I am grateful to be able to live, learn, and play on these lands. My name is Dr. Leonie Herx, and I'm a specialist palliative care physician, head of palliative medicine at Queen's University, medical director of palliative care at Kingston Health Sciences and Providence Care Hospital, the immediate past president of the Canadian Society of Palliative Care Physicians, where I've been a peer-elected member of the board of directors for the past 9 years, and I'm the chair of the Royal College Specialty Committee in Palliative Medicine. Palliative care is a holistic approach to care that focuses on enhancing the quality of life for persons living with life-threatening illnesses and their families by means of early identification, impeccable assessment and treatment of symptoms, including physical, psychosocial, and spiritual concerns, and supports a person in living well until they die, medical assistance in living, or MAIL, if you will. Palliative care does not hasten death and is internationally recognized as a practice distinct from MAID, philosophically, clinically, and legally. Only about 30 to 50% of Canadians who need it have access to some kind of palliative care of unknown quality, and very few, only about 15%, have access to specialist palliative care to address more complex issues. You are less likely to receive palliative care if you're a poor, Indigenous, homeless, incarcerated, or live in a rural area. Studies from around the world have shown that early integration of palliative care improves quality of life, reduces anxiety and depression, reduces caregiver distress, and may even help people live longer. An integrated palliative approach to care should be provided as part of the management of all serious illness starting soon after diagnosis. However, due to the ongoing stigmatization and misunderstanding of palliative care as end-of-life care, we are often only involved much later. When patients' palliative care needs are not met, the ensuing physical, emotional, and spiritual suffering can lead them to feeling depressed, hopeless, and a burden to others. Many of the factors driving requests for MAID. Earlier palliative care can alleviate suffering before it becomes irremediable. Failure to do so, as asserted by Dr. Romaine Gallagher and colleagues, should be seen as medical error. MAID was established for exceptional circumstances, not as a routine procedure for ending life as a solution to suffering that could be addressed through health and social supports that help people live a dignified life. Since Bill C-7, we now see countless cases in the media and in our own medical practices of people requesting and receiving MAID due to a lack of basic supports needed for living, including a lack of palliative care, home care, and disability care. Health Canada's annual report on MAID shows that a significant number of people receiving MAID had no palliative care at all, 15%, or palliative care much too late, 18% within 2 weeks of receiving MAID, and 19% within 4 weeks of the request, and another 3% unknown. So at least 35% of those receiving MAID had little to no palliative care. This is consistent with a Canadian study by Monroe in 2020 that showed 40% of patients had no palliative care prior to requesting MAID. This should be seen as a failure of our healthcare system. With removal of the 10-day waiting period under C-7, these numbers are likely to increase further because the impetus to call palliative care is not there. In Carter versus Canada, the Supreme Court of Canada discussed what possible impacts implementing a law for assisted death prior to securing universal access to palliative care might have on the development of a strong palliative care system. With almost 6 years of lived experience now, we have seen significant deleterious effects of the impact of MAID implementation on palliative care practice, including diminished resources and increasing distress experienced by palliative care clinicians. I'll provide some examples. Some health authorities incorporated MAID into palliative and end-of-life care program roles. This has led to palliative nurses leaving their jobs because they felt unable to provide palliative care. In Ontario, some hospice palliative care nurse practitioners are using their full-time paid palliative care roles to provide MAID. Palliative care clinicians are having to spend a significant amount of time on administrative issues related to MAID, which takes away from time to provide palliative care. There's decreased access to specialized palliative care beds when health authorities require hospices and palliative care units to admit patients for the sole purposes of administering MAID. And we see increasing moral distress in palliative care clinicians from forced participation in MAID due to some health authorities mandating that MAID be provided in hospices and palliative care units or lose funding. This is resulting in retention difficulties and early retirements from palliative care, which is accentuating and accelerating the already critical shortage of specialist and generalist palliative care physicians. We also see patients unwilling to access palliative care because they associate it with MAID and are afraid palliative care will hasten their death or MAID will be provided without their consent. Patients are accessing MAID due to a lack of palliative care provision, and patients are requesting MAID because a trusted physician suggested it to them.
Dr. Hertz, you'll have to wrap up very quickly.
Sure, yeah, I have 10 seconds. Currently, Canadians have a right to medical assistance in dying, but not to medical assistance in living. Having accessible, high-quality palliative care needs to be a universal right in Canada. Thank you.
Merci beaucoup. Et maintenant, à vous la parole, Dr.
Thank you very much, Dr. No. The floor is now yours for 5 minutes. Thank you very much, Mr. Chairperson. I'd like to begin by thanking members of the committee for the opportunity to share with you my experience and observations on MAID. I have been a family physician and palliative care physician for 37 years, and I've served as an expert witness on MAID and palliative care at the Gladue-Truchon trial in 2019. The rest of the details are in the 18-page brief that I have already submitted to the committee. The brief contains several references to various reports that I invite you to consult. In it, I report on the current situation, address the issues of expanding access to mental health to minors, and more particularly that of advance requests after a diagnosis of Alzheimer's and other major neurocognitive disorders. After over 6 years of experience with MAID in Quebec and almost the same period in Canada, it is clear that the famous slippery slope promised by opponents has never occurred and that MAID is administered rigorously and in full compliance with the law. MAID is a medical, moral, ethical, legitimate form of care and is perfectly legal. And there is no incoherency between MAID and palliative care, quite to the contrary. Together with palliative sedation and refusal of treatment, they are interrelated and complementary end-of-life options, the choice of which rests exclusively with the competent and well-informed patient. In Quebec, about 80% of patients who died with MAID were already receiving palliative care. The remaining 20% freely refused palliative care, and they have the right to do so. Alzheimer's and advance requests. This is the first expansion of access that is long overdue in the opinion of an undeniable majority of Canadians, and there is broad consensus. In Quebec, in fact, there were two pan-Canadian surveys which demonstrate that most Canadians and Quebecers sought such directives. In Quebec, an independent panel of experts mandated by the government to study the issue from ethical, clinical and legal perspectives worked for 2 years from 2017 to 2019 and tabled a report that recommends, after a remarkable exercise, both documentary and reflective, that advance directives be made available. The reference to this exhaustive report in French and English is available in my brief. My brief also refers to the Quebec Forum held in January 2020 and the report of the Special Commission of the Quebec Government, which was tabled in December 2021 and which also recommends the introduction of advance requests. I'd like to refer to a survey of physicians and the public by the Collège des Médecins du Québec, and especially on the position of the college endorsed by its board of directors in December 2021 on advance directives in mental health and minors. I commented at length on the quote-unquote joyful dementia that is sometimes invoked by some who oppose advance directives, and I propose in my essay safeguards that should be put in place based on the person's own choice of observable and objective signs of severity of the disease at the stage of incapacity and not at the clinical stage. These directives must be binding and not subject to the veto of the family and friends, as is already the case with mandates in case of incapacity, wills, and in Quebec, the Registry of Advanced Medical Directives. Now, regarding vulnerability, I refer to Gladue-Truchon decision of the Quebec Superior Court, which heard numerous experts over a period of 2 months and analysed a great deal of evidence. And now let me quote from that decision. 1. medical assistance in dying as practiced in Canada is a stringent and rigorous process which in and of itself has no obvious defects. 2, physicians involved are often able to assess the capacity of patients to consent and to detect signs of ambivalence, mental disorders affecting or likely to affect the decision-making process, or cases of coercion or abuse. 3, the vulnerability of a person requesting medical assistance in dying must be assessed exclusively on an individual basis according to his or her own characteristics and not according to a benchmark group of quote-unquote vulnerable persons, and beyond the various factors indicating vulnerability that physicians are able to identify or detect is the patient's own ability to understand and consent that proves to be the decisive factor. And you should read the decision that's also available in English, Mental Health. There was an expert panel that demonstrates that mental health can no longer be excluded from eligibility and that it is now important to consider the guidelines and safeguards to be put in place prior to the expiry of C7. Now, minors. I refer once again to my brief to the position of the Collège des Médecins du Québec, which I endorse, regarding the experience of Belgium and Netherlands since 2002 with its Groningen Protocol, and to the 2018 document of the Canadian Pediatric Society, which conducted a survey of Canadian pediatricians, which demonstrate that pediatricians in Canada do receive such requests and discuss these issues with parents and children. Now, I'd like to illustrate this with a situation experienced in Quebec last summer of a young man of 17 years and 9 months with a very aggressive cancer who would have liked to receive MAID and who was ineligible because he was short by 3 months. Thanks again for the invitation, and I'm now available to respond to your questions and any questions you might have after reading my brief. Thank you very much, Dr. No.
First round of questions, and I'll transfer back to my co-chair, Senator Martin.
Thank you, Mr. Garneau. We'll begin with a question by Michael Barrett, please. 5 minutes, and I'll give a 30-second warning.
Well, thank you, co-chair, and thanks to the witnesses for appearing here today. My first question is for Dr. Herx. I was interested to hear you reference the number 35% as those who accessed MAID but didn't have access to palliative care. We recently heard testimony, doctor, from a witness who was here as an executive advisor on behalf of Health Canada, Ms. Abby Hoffman. And her position on behalf of Health Canada was that most people who have had MAID had palliative care. What's your response to that, ma'am?
Yes, thank you for the question, Madam Chair. There's a really significant problem with the data that's being collected by Health Canada, and that was reported by Ms. Hoffman, and I did listen to her testimony. I'm very aware of the Health Canada reports. Those rely completely on self-reporting by MAID providers, and there is no ability right now in Canada to measure the quality or quantity of palliative care that is being provided or who is providing it. We do not have any standards or ability to collect data nationally as there are from MAID's statistics. And so unfortunately, there's no ability to make those conclusions. We know that clinicians have a large misunderstanding about palliative care and don't understand how it can make such a difference in someone's life early on to prevent the point where you get to irremediable suffering. And so how palliative care is explained to patients when they request MAID is only as good as the person who's giving the explanation. And so we know that patients often get wrong information and have a very limited understanding. But I think one of the biggest problems is that if you're only hearing about palliative care when you get to the point where you're asking for death, then we have a big problem because we failed upstream to treat the problem in the first place. And that's the part that we need to focus on, is that there's so much suffering that's not being alleviated because palliative care is not readily available to patients when they need it, when they start having symptoms and suffering due to serious illness. It needs to be integrated early into chronic illness. And right now we're seeing 35% of people in our very best data, which is subjective reporting by MAID providers who may not understand palliative care, what's involved with palliative care, who have palliative care at maybe 2 weeks, maybe within 2 weeks of the request, which is probably much too late, or maybe not at all, right? So, right. Even 4 weeks prior to the request, I would say, is inadequate to prevent irremediable suffering.
Right. And so is it for, I don't want to infer something that you weren't intending with your remarks. So could you just clarify very quickly, if you wouldn't mind, what you think about the claim from that same witness or that same testimony that there are very few cases of non-compliance per year? Just quickly, if you could.
Yeah, we cannot draw the conclusions. We do not have the data to draw those conclusions.
Okay. I believe that you said, and pardon me for paraphrasing, that palliative care does not hasten death and is internationally recognized as a practice distinct from MAID. Can you comment on the specific statement in that same testimony from our last meeting by Health Canada that MAID and palliative care are not separate?
Yes, absolutely. So the national palliative care organizations, including the colleges who are responsible for setting the competencies for the certified training programs, including a 2-year Royal College program in palliative medicine and a 1-year College of Family Physicians, much different than the CM continuing medical education modules we're talking about for MAID. Those certification programs and the national bodies for palliative care and the international organizations recognize that palliative care does not hasten death at all. It accompanies people through suffering and helps them live well until they die. And so that the difficulty we are experiencing in palliative care is that MAID has been forced into palliative care by health authorities and people who are non-palliative experts and said, you have to provide it in your hospices and your palliative care units, and that is forcing us to be involved. So that's also a bit of a misrepresentation. I think that Health Canada reported that they're not completely separate because they've been forced to go together by external authorities who are not experts in palliative care.
Right. And so I think I have 30 seconds left. And just very quickly, Dr. Herx, and thank you for your responses. Do you have any thoughts on the regional variation of MAID rates with a very high number, the highest in the world, coming from Victoria, BC? And if this causes you concern?
Very alarming. I think in any medical procedure, if there is a high, out of balance area where a procedure is being done at much higher rates than anywhere else in a country or in a program, that is put under a significant scrutiny to review and make sure what is happening here that's so awry with the rest of the country. And I would hope that that is going to be happening to assess the situation in Vancouver Island.
Yeah, thanks very much, Dr. Herx. Thank you, Madam Co-Chair.
Thank you.
Thank you. The next person will be Dr. Fry for 5 minutes.
Thank you very much. And I want to thank everyone for coming today and giving us their time on a very complex issue. I'm a family physician, used to be a family physician for very many years. And I find that what I'm hearing today are people suggesting that it is one thing or the other, that you either seek MAID or you seek palliative care. And I don't think either are true. I really do, in terms of my own experience with patients, is that palliative care has a place and a lot of people wish for palliative care. And then after that, they may get to a point where they decide that whatever is going on with their lives is unbearable and that they want to access MAID after that. Now, you have questioned Ms. Hoffman's and Health Canada's report about that 82.8% of people who access MAID had palliative care given to them. I think the either or concerns me a little bit. The idea that there is one silver bullet that everyone, if they accessed, would be able to get better. I think Dr. Node said it extremely well. I almost got up and applauded when he said that assessing or giving a patient MAID or palliative care or whatever else you may do to give them support is about the patient. It's not about whether the physician believes that their decision is the most important decision for the patient. It's about knowing and assessing your patient and knowing when your patient has come to the point where they can trust you to tell you, you know what, this has been working well. I am feeling very good about myself, but I really don't want to do it anymore. I've just had it, my years, etc. And I think it's really important for us to start talking about what are the things that happen if a patient who is in palliative care says, I would like to have access to MAID? What is it that you would say to that patient, Dr. Herx? I know that Dr. Node talks about the patient and the patient's limits, the patient's tolerance. It is at the end of the day about the patient. And I mean, I think the issue of advanced directives is something I'd like to get in, but I don't think I'm going to have time. So I would like to hear Dr. Node talk a little bit about how you make a decision in the best interest of your patient, Dr. Node, when your patient is going through, the end of life, when they're going through pain, etc. How do you make those decisions on the individual case-by-case patient?
First, Dr. Hertz, followed by Dr. Node.
No, I would prefer Dr. Node to answer the question.
Okay.
I will ask Dr. Hertz later.
All right, Dr. Node.
Oui, merci beaucoup.
Well, thank you very much for the question. It's indeed very important. You know, those who oppose MAID have sought to oppose it for a long time, even palliative care. They believe, in fact, there is no opposition or incoherency between the two. These are interrelated forms of care. Now, let me refer to the situation in Quebec. In Quebec, all public health institutions, when the Quebec Act was enacted, had an obligation to offer that form of care to all Quebecers and make it available. The idea isn't to foist it upon them, but to make it available. The only exception concerned palliative care hospitals, which are autonomous, which are governed by their own board of directors, which in 2015 said they would never engage in MAID because it flew in the face of the principle of palliative care. Now, determining what the best way is of dying for a patient is smacks of paternalist medicine. As doctors, our role is to inform patients of the options at their disposal, to ensure that they understand them fully, and to respect their choices, regardless of our own choice, values, and convictions. So the end-of-life options, well, there aren't 50 of them. There are 4. Palliative care, MAID, palliative sedation, and the refusal or cessation of treatment. Now, there are 36 palliative care hospitals in Quebec. All of them have refused to offer MAID. Over half of them now also offer MAID in their palette of care, and they don't offer inferior palliative care as a result. This was in response to the demands from Quebecers, the interests of ill, sick patients. It was always in the interest of these patients who asked for MAID to give them that option because they didn't want to suffer. They were...
Thank you,
There's
Dr.
actually
Node.
less than 10 seconds.
Oh, my goodness. I just wanted to ask Dr. Herx. I said she is making a point that there must be more palliative care available to people. But I do agree with Dr. Node because I think it is paternalistic to tell a patient at the end of the time when that patient makes decisions what is best for the patient or not.
Okay, thank you, Dr. Fry. Next, we'll have Monsieur Theriault for 5 minutes.
Oui, merci.
Thank you very much. Yes, Dr. No, I think that you're right to refer to the Quebec experience to the extent that in a continuum of care, Quebec provides for the possibility of a request for MAID rather than seeing it in opposition or as incoherent with palliative care. Now, as far as palliative care is concerned, when Dr. Hertz said we need a holistic approach, well, I agree wholeheartedly. But, and here's my question, how does palliative care and the process of accompanying a sick person through to their death, that can create a feeling of failure because a patient may have received good palliative care, might feel completely serene, and might be ready to let go. That could be considered a success story of palliative care in accompanying the patient to death. Do you not agree with that? Absolutely, and I believe the question was for me. Well, for both of you, in fact. Well, yes, you're entirely right. it shouldn't be seen as a failure per se, but as part of the continuum of care. And once again, MAID is legitimate and perfectly legal. It's not a shameful form of care. I've been involved in palliative care for 37 years and in MAID from its onset, and I've never promoted MAID per se. To my mind, it's no more of a worthy form of care than palliative care or sedation, but it provides patients with all the options that are available, and they need to make the decision in line with their own values, beliefs, and convictions. Now, there are some palliative care folks that are opposed to MAID based on religious convictions, that they are sometimes thinly veiled, sometimes they're ideologically driven. We need to evaluate this or assess it from a psychological standpoint. Palliative care is crucial and must be provided to all Quebecers, and so is MAID. Some doctors see this as a failure in some ways, and they think, well, I promised you to the patient to accompany them through to the point of death, and now you're making a choice that I don't agree with, so unfortunately, I can no longer see you through to the end of your life. Now, as a palliative care doctor, when I get a request from a patient who says that well, there's nothing else to do, I tell them that there's a lot else that can be done, and I'll stay with them right through to the end, regardless of the end-of-life choice that they make. I'll be with them by their side, and I'll respect their choices. Question.
Unfortunately, not everyone in Canada, and you mentioned everyone in Quebec, should have access to palliative care. It is not available. I explained the statistics of 30% to 50% of patients have access to palliative care, and they don't have it earlier enough in their disease trajectory to make a difference to reduce this place they get to with irremediable suffering. So it's not about whether MAID is right or wrong. It's that people do not have access to palliative care, and they have unnecessary suffering, which leads to MAID requests, and that's something that can lead to wrongful death, and that's not okay.
Donc vous êtes encore dans la logique.
So you oppose MAID, basically, and if someone is asking for MAID, in your opinion, that means that they haven't gotten good palliative care, and then palliative care amounts to the only solution to die in dignity, in your opinion. I get that. But Dr. No, the committee will have to make recommendations or not to the criminal code, but before we make amendments to the criminal code to expand MAID to include, for example, dementia, legislators need to be convinced that there are possible safeguards to protect the free choice of patients. Could you please speak to these safeguards? Response. Yes, thank you very much for the question. In my brief, I proposed a number of clear, objective safeguards that will respect the patient's choice to self-determination while they are competent to make such choices. And very concisely, after meeting with a doctor and signing a form, and that form or that request has to be renewed after a certain time when it lapses. The patient has to check off a number of criteria in terms of incompetence deemed by the state and the designation of a third party whose mandate will not be to determine that their end of life should come now, but in fact to ask the professional healthcare team to proceed with an assessment to determine whether the criteria have been met. And I think that can be put in place easily.
Next, we have Mr. McGregor for 5 minutes.
Thank you, Madam Co-Chair. Dr. Herx, maybe I'll start with you. I was a member of Parliament in the 42nd Parliament when the original debate on Bill C-14 was going on in 2016. And I remember the very passionate debates in the House during that time. There were opinions across the entire spectrum voiced by members. And concurrently with that debate, there was also an acknowledgement that we as a country needed to do better in terms of giving patients palliative care options. And I know, in my own community in the Cowichan Valley on Vancouver Island, Cowichan Hospice has tremendously benefited from the building of a new palliative care center, which has expanded the number of beds that is available. But I guess what I want to ask you is I want to take a sort of a little walk down memory lane with you, like over the last number of years, because I guess what I want to know from you is, the original Bill C-14 was passed in 2016. We had all-party support in 2017 for the palliative care framework. And I guess from your perspective, Dr. Herx, I want to know, like, when you saw that renewed focus on palliative care in Canada that came first in 2016 with the debate on C-14, but then with the passing of a palliative care framework, did you see an improvement, in 2017, 2018, 2019, and then did it just ebb? Like, have we just sort of lost the plot a bit and we need to refocus attention? I just want to get a sense from you what those previous years were like.
Yes, thank you very much for the question. Thank you, Madam Chair. So, certainly there was a renewed attention, as you said, on the importance of palliative care, and it was indeed positioned as something that could alleviate suffering that might lead to a request for hastened death by both the Supreme Court and in the C-14 legislation. And we were so fortunate to have supported through the Canadian Society of Palliative Care Physicians the Bill C-277, which created the National Framework for Palliative Care. And what that really allowed us to do is put together all the good work that's been done across the country and informed by international standards to kind of solidify what we need to achieve in Canada to make palliative care a reality. But unfortunately, we haven't really done anything further than put a framework on paper. And what we need is the money and the infrastructure to get the boots on the ground. We now have clearly defined national competencies for all professionals to provide a palliative approach to care for their patients and for the specialist training that is needed, but they are not embedded into curricula across the country. We do not have quality standards to evaluate what palliative care is happening across the country. So that gets back to the Health Canada data. Like, we just don't know what's happening and who's providing the care, although now we have these credentialing programs. So we need a national system that's linked to Accreditation Canada standards that's administered so that provinces collect data on outcomes for patients that are patient reported, as well as the quality standards, to make sure that provinces are accountable for improving both the quality of palliative care and the accessibility of palliative care. And that will take a sustained investment of resources over time to get those trainings embedded, to get the standards up, and to hold the provinces accountable through accreditation standards. That's absolutely needed, and we haven't seen any of that. There's no money in the last federal budget, and that needs to change. 95% at least of Canadians don't want to die via an assisted death, so let's put some money into supporting the needs of all of those people who don't want MAID.
Yeah, fair point. I think we will struggle as policymakers to always try and respect the agency of the patient. We want them to have the best available care so that they can make the best decisions for themselves. But maybe, Dr. Noda, I can get you to chime in on the same theme. When you look back over the last number of years, like since 2016 and 2017, do you have any thoughts on how the national attention of palliative care has ebbed and flowed and what more needs to be done?
Dr. Node? He seems to be frozen on the screen. Dr. Node.
He's on mute, I believe.
You have 35 seconds.
Yes, sorry, I didn't understand that the question was for me. I'll proceed if I may. So, yes, listen, we all agree, and as I said, there's no opposition to this. Palliative care needs to be available for everyone who needs it. Now, in the city of Quebec, I hear an argument that because MAID now exists, there hasn't been as much care given to providing good palliative care, and that has been defunded. And I've never seen this demonstrated by way of evidence. I think that palliative care has been chronically underfunded for far too long, and that has nothing to do with the arrival of MAID. We need to stop pitting one against the other. It's not about good palliative care and MAID being in opposition. They both need to coexist, and essentially we need to respect patients' choices, who will make a free, informed choice.
Thank you. Mr. Co-Chair, I will turn it back to you for the Senator's questions.
Thank you, Madam Co-Chair. On va aller au sénateur.
Turning to senators now, and once again we'll start with Senator Meji. Senator, you have 3 minutes. Thank you very much, Mr. Chairperson. My question is for Dr. No. What would you respond to the argument that is often bandied about that were there better palliative care, there would be fewer requests for MAID? What would you say to that argument? Response. Thank you very much, Senator. That's an argument that naysayers have put forward. In Quebec, we started talking about MAID in 2009 when the Commission put in place measures through to the enactment of the bill in 2014. We've heard this argument constantly. We know that it is false and unfounded, and the experience of the past 6 years have demonstrated that it is a bogus argument. There are no patients that receive MAID because they haven't received good palliative care. That's a fact. In Quebec, there is excellent statistical data on this compared to other Canadian jurisdictions. There was a commission that was struck by the Quebec government on the end of life that compiles rigorous statistics. And as I mentioned in my opening remarks, 80% of the ill in Quebec who receive MAID were already undergoing palliative care, already receiving palliative care, and the other 20% voluntarily refused palliative care. Because that is part and parcel of the obligations that we have when we meet a sick person who's making a request for MAID, that they consider all the options at their disposal. And we can propose palliative care if they're not already undergoing palliative care. As I said, 20% of people who are receiving MAID have voluntarily refused palliative care. And I also referred to palliative care hospices that at the outset refused to offer MAID. And we know that there were ill people who were 2 or 3 days before their death who were transferred to hospitals to receive MAID, and now over half of these palliative care hospices offer MAID, and their palliative care remains very robust. And I'm sure that the exemption will be lifted when the Quebec legislation is amended. So this is a bogus argument. The proof is in the pudding, and we have evidence that that argument was bogus right from the beginning. Is there any time for a small, short question? Yes, 30 seconds. In your written brief, are there any safeguards to expand MAID to mature minors and for whom those individuals have only a diagnosis, a sole diagnosis of mental health issues? Yes, absolutely. In my brief, I referred to the Collège des Médecins du Québec's position in light of the experience in Quebec and the Netherlands, and psychiatrists' reports who've proposed safeguards, including the Association of Psychiatrists of Quebec, that has produced a voluminous document referring to safeguards that should be put in place. It needs to be done hand in hand with experts. In Belgium and Netherlands, there is a requirement for 2 physicians and the opinion of a psychiatrist as far as maturity is concerned. You need to understand that teenagers of 14 and 15 are not immature. Quite to the contrary. Often those individuals, those young people who have been very sick, have a level of maturity that most people of their age don't have. So it's a false argument that because they're under 18, they're not competent to make such a decision. And I think that as specialists, we are very well equipped to assess that level of competency. Yes, these physicians are calling for additional safeguards to the measures we currently have.
We have 3 minutes.
Thank you, Mr. Chair. My questions, I have 3 short questions for Dr. Hertz. What proportion of Canadian palliative care physicians currently also provide MAID?
So we don't have any recent statistics on that, Senator Kutcher. Thank you for the question. Our most recent survey from the Canadian Society of Palliative Care Physicians showed that 92% of palliative care physicians did not provide MAID, but we haven't resurveyed recently.
Thank you. When MAID became available in Canada, was there a consensus amongst palliative care physicians that MAID should be provided?
And sorry, what do you mean should be provided?
to people who wanted MAID instead of palliative care? Was there consensus amongst palliative care physicians that should happen?
So the consensus from palliative care physicians was that hastening death and ending someone's life is not part of the practice of palliative care. And certainly there are some individual palliative care clinicians who choose to make MAID practice part of their medical practice, like you can in any specialty. You can build a MAID practice, but that was very clear and consistent in the palliative care community. It's not part of the philosophy of palliative care.
So it would be correct to say that there was no consensus.
No, we did not discuss anything to do with whether MAID was right or wrong. We don't make legal decisions. We discussed as a medical profession what was a competency within our medical discipline, and ending someone's life is not part of that.
Yeah, so there was no consensus that ending someone's life was part of what you were doing.
No, there was consensus that ending a life was not part of palliative care, and it's not part of the skill set of a palliative care clinician.
No, I hear you. That's just saying it the other way around. Is there consensus now amongst palliative care physicians that track 2, as in C7 MAID, should be provided by palliative care physicians?
And we have not surveyed our clinicians. Those aren't typically the patients that we're involved in caring for. So it's the people with the reasonably foreseeable death criterion that are the patients we provide care for.
So you would have information whether or not palliative care physicians as a group are in favor.
Would not have that information. Would not have that information.
What would you be your
But
hypothesis?
I think the point is that this is not about if people are in favor or not of MAID. This is about how do people have access to the care that they need to live. And currently in Canada, we don't have the infrastructure for people to have palliative care.
I don't think people are debating that. We all agree upon that. The issue, I'm just trying to understand within the community of palliative care physicians whether there is consensus about whether Track 2 MAID should be provided.
From the Canadian Society of Palliative Care Physicians and the Canadian Hospice and Palliative Care Association, certainly they spoke out against Bill C7 and thought that it was putting too many vulnerable lives at risk. And so I would say the consensus from the two national organizations is that it was wrong to extend MAID to Track 2.
Okay, thank you very, very much.
And that's again back to resources, right? They're not available.
Thank you very much. We'll now go to Senator Dalphond.
Merci, Monsieur le Co-Président.
Thank you, Mr. Co-Chair. My question is for Dr. No. Perhaps in the previous panel you heard Dr. Pajot. He assumed to make the distinction between not preventing death from occurring, which he understands in the advanced medical directives, and causing death, which is the case in advance requests for MAID. I understand the distinction from a legal standpoint, but from a medical standpoint, is there any difficulty? Well, thank you, Senator. No, not at all. The only difficulty arises on the part of the caregiver, him or herself. The opponents use the term euthanasia with contempt. And, you have to look at the Greek roots of euthanasia, which describes it as the beautiful death. And in Belgium, it's called euthanasia. There's no reluctance to call it for what it is. It is an act of euthanasia MAID. It is a medical act to alleviate suffering. What is the best way of achieving this? Well, the onus isn't on us as caregivers to determine what it is. When it comes to end-of-life dignity, when it comes to the best way of dying, I don't have a magic response, and it's not up to me to decide what a sick person should do. My role is to explain to the sick person what their options are in detail and to the best of my ability. So obviously, when you are opposed right from the outset, right out of the gate to MAID, and look, when you look at the surveys at the beginning, 80% of Canadians are in favour of MAID, and there's even a higher proportion among doctors in Quebec. The Collège des Médecins polled doctors on that issue. Now, if you ask the question, are you in favour of an expansion, obviously the answer is going to be no. There'll still be 10 to 20% of the public who'll be opposed to an expansion of eligibility or accessibility to MAID. But at the end of the day, you have to consider the wishes of the majority of Quebecers and Canadians, and one can debate on the dignity of end of life at length, but to my mind, the best way to provide dignity is to leave it up to the individual to determine what dignity at end of life is for them. Now, some people will say, God gave me my life and it's up to him to take it from me. And as a palliative care doctor, I will respect that 100%. These people will sometimes be in agony through to their end of life. We've seen this from members of our families. People will die with their mouths open for 10 days, and then there are others who do not envisage the end of their life to be like that. They saw their father dying like that, and that's not how they wish to put an end to see an end to their lives.
I believe it's Senator Martin. You switched with Senator Wallen for this.
No, Senator Wallen.
Okay. Senator
Yes,
Wallen, you have 3 minutes.
Thank you very much. A question for our witness, Leonie Herx, if I'm saying that correctly. MAID is the law of the land. You understand that, correct?
Oh, no one's debating whether this is not about MAID being right or wrong. This is about access to care that relieves suffering before it becomes irremediable.
But you have said that in answer to one of my colleagues' questions that you've not really surveyed your clinicians on the question of MAID specifically and whether they would offer it. You said no palliative care clinician would want to do that. Are you saying that palliative care clinicians, if asked by a patient to discuss MAID or have someone come in and hear their request for this or to explain the options, that you would refuse to do so?
Oh my goodness, absolutely not. I'm not sure where that idea came from. We provide our patients with all the information they would like to make a choice that's best for them, but we have special expertise that comes through our long certified training program, and the palliative care has come so far in the past 10 to 15 years in terms of its advances to understand symptoms and especially spiritual and psychological distress, that we accompany people and we have specific expertise to support people in focusing on living and reframing hope. And so we're not there to hasten somene's death. That doesn't mean that a person
I'm not talking about hastening their death.
MAID.
I'm asking if they ask you and say, I've been through the palliative process. I personally see this as a continuum. I would like to go to the next step now and choose MAID. Then what do you do? Do you bring in someone who will discuss this? Do you give them access?
No, we discuss all options with our patients.
How do you do that?
Well, I mean, I can't go into specific examples, but we make sure patients have all the understanding they need, which includes what they understand about palliative care. And one of the biggest...
I'm not talking about palliative care. I know you do that.
No,
I'm
that's
talking about when a patient asks you to say, okay, I have come to the end
about how I would respond.
Of my willingness to pursue palliative care, and now I would like to answer the question. Discuss MAID. Oh, this is the question.
Yes.
That I would like to choose MAID at this point. Then what do you do?
Then I will first make sure what is going on with this patient and what did they understand about palliative care. And that is crucial because palliative care is so misunderstood by people, and people don't understand what natural dying and death looks like.
I'm not asking that question, please. Our time is very short. I would like to know what it is that you do. When
how
a
we
patient
respond.
says that, what do you do?
Yes, that's
do you
what I'm
call a
explaining.
local MAID provider?
I'm explaining that first we explore the whole question with the patient and ensure they understand what all the options are, including palliative care, because they may have misconceptions, and palliative care is very
if they're going through
stigmatized.
MAID, or going through palliative, they've understood that. Now they've come to a new conclusion.
Thank you. We're going to have to end this round.
Thank you.
So thank you very much. And Senator Martin, over to you for 3 minutes.
Yes, thank you. My question is to Dr. Hertz, and I've asked this to several other witnesses, and I just want to be clear. We have MAID and we have palliative care as part of this spectrum of care. But in British Columbia, I've heard from some witnesses that there is a lack of funding or less funding for palliative care because there seems to be a certain, when I say competition, I don't have a better word for it, but would you speak to any examples, such as the one that we have seen in BC, the Delta Hospice for one, and whether there has been less funding available for palliative care, even though we have this national framework? Dr. Hertz?
Yes, thank you, Senator Martin. So unfortunately, and that was an add-on to the question Mr. McGregor asked me earlier, is that while we haven't seen new investments in palliative care in terms of improving accessibility and being able to measure the quality of palliative care that's being referred to in the Health Canada reports, we have actually seen a loss of palliative care resources. And as I referred to in my brief remarks, and there's further details in my brief, my written brief, existing palliative care resources have been used to provide MAID. So palliative care funding in different provinces is being used to fund MAID programs. So you have less access to palliative care than we had before MAID was legalized. So we have clinicians who are now being asked to provide MAID, palliative care nurses, hospice palliative care nurses, who have, lots of them have now left their jobs because they're so demoralized with being able to provide the palliative care that they went into their job for. And it's been lumped into budgets with palliative and end-of-life care, and MAID is being funded out of existing palliative care dollars. So it is actually compromising already scarce resources for palliative care. And as I mentioned, some hospices have been forced to admit people just to provide the procedure of MAID, not to provide holistic palliative care, but they're using this scarce palliative care resource at the cost of other people who want palliative care in a natural death not being able to access it. So we have had devastating impacts on palliative care in the last few years.
Okay, and I wonder if I can use my remaining time for you to finish your answer to my colleague, Senator Wallin, about what your response would be to a patient in palliative care who wished to access MAID.
Absolutely. So first and foremost, our expertise is in addressing suffering. And so we come alongside a person to understand what it is that's going on in their unique context. And not all requests for MAID are that somebody wants to immediately terminate their life. Often requests for a desire for death and MAID are suffering that needs to be heard, and lament and grief. That's a normal part of coming to terms with the possibility of your own death. And so we have all kinds of interventions and supports that can help reframe living for people, and people do want to live. So first, our responsibility is to help make sure what it is a person is actually asking for, and that they understand all of the things that are available to them. And absolutely, we talk to them about the procedure of MAID and what that is. And if that's what they want, then we make sure that they have access to it. And that is not precluded from being, because you don't, they're not separate in the sense of you can't have MAID if you have palliative care. And I just want to be clear on that. We provide palliative care to everyone regardless, but MAID is not part of palliative care. It's a separate medical procedure, and it shouldn't be provided through existing palliative care resources or in the context of palliative care.
Thank
you, Dr. Herx. I'd like to, this brings the second panel to...
Mr. Chair, can I just make a quick point of order?
Who am I looking at?
Over here.
Oh, yes, Mr. Maloney?
Well, actually, I'm not sure it's a point of order, but I haven't had the benefit of seeing Dr. Hertz's paper, and I'm not sure anybody else has either. Perhaps that's because it hasn't been translated. So I'm wondering if, to the extent that the data she referred to is not in her paper with respect to people leaving the industry and it detracting from the resources available to the palliative care sector, she could provide that information to us in writing.
Would you like to respond, Dr. Herx?
Yes, thank you. It's all in my brief, and I'm sorry I submitted in English only, so it is with the clerk of the committee.
Okay, thank you.
Very good. Thank you very much, Dr. Herx. Merci beaucoup, Dr. No.
Thank you very much, Dr. No, for your testimony this evening.
Hearing from you and you answering our questions. And we will now suspend in preparation for panel number 3. Thank you. Good evening.
Thank you, Mr. Co-Chair. We will have 3 witnesses for this third panel, and if I can just make a few comments about what will happen. So before speaking, please wait until one of the co-chairs recognizes you by name. Reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. Interpretation in this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. When you're not speaking, please keep your microphones on mute. And with that, I'd like to welcome our witnesses for the third panel. As an individual, Audrey Baylis, retired registered nurse. Diane Riva Gwartz, nurse practitioner, primary health care. And Dr. Sonu Gain, professor. Thank you all for joining us, and we will begin with opening remarks for 5 minutes each. First, Ms. Baylis, and then Ms. Gwartz, followed by Dr. Gain. So Ms. Baylis, the floor is yours.
Thank you, Madam Chair and committee members. The reason I requested to be a witness before this committee is twofold. One, to have legislation changed, A, be able to pre-plan end of life while still a healthy individual. Example, when you make your will. And B, be able to make a choice. And the second part would be education, as I believe that attitudes do not change without education. My husband had MAID November 23rd, 2020. He had a double bypass in 2000, a pacemaker defibrillator installed in 2009. He had good quality of life until 2019, when his condition began to worsen. In the spring of 2020, his family doctor advised him that there's no further treatment available to improve his quality of life. The doctor, who was very proactive, discussed what to expect for quality of life up until his end of life and described his choices, palliative care or MAID. For the next 6 months, we traveled Ontario visiting relatives in France, and his condition worsened. He sought MAID. A date was set for November 29th, his birthday. Excuse me. However, his condition severely got worse, and on November 23rd, he had MAID. The family all came the morning of the event, and we had nothing but good memories because he was there for all the conversation and said goodbye. And when the doctor came, she said that she was ready. And Lester gave them a hug and said he loved them. He went into the bedroom and laid in the bed, and I laid beside him and held his hand, and he said goodbye. The doctor asked him again if this is what he wanted, and he responded, yes. What better way to end a life, as we only have good memories? The reason that I am so passionate about pre-planning is because prior to the age of 31, I had 3 cardiac arrests, 2/3 of my stomach surgically removed, had 3 children, and worked full-time. I did worry about my future, so I did put a plan in place for end of life 50-plus years ago. I have a document signed by my family and friends for them to take me to Switzerland for medical assistance death. The document clearly states my wishes and criteria for my family to make that decision. To conclude, the need for pre-planning is to ensure you have a choice on how you would want to proceed with your end of life, beyond religion and external influences, prior to a medical event or accident that will make you incompetent later to make that choice. The second part, education. I recommend that the federal provincial initiative to add to the curriculum in all medical teaching institutions, last phase of life, up to end of life, emphasizing the need for the patient to be part of all medical discussions. This mold of talking to the family, not the patient, needs to be broken. I would like to see this done in 3 parts. 1, the last phase of life to end of life. This is when the doctor states that he or she has no further treatment to offer to the patient to enhance their quality of life. Discuss with the patient what they could expect as their condition worsens up to the end of life and what their choices are. The second part, palliative care and MAID. These should be taught in depth. And 3, continuing education. My final thought, I personally find it hard to understand the negativity around MAID, as in both scenarios, you will die of a drug unless you die of a coronary. Palliative care is a longer process where you are well cared for and kept comfortable with a drug until your body shuts down, most of the time by the same drug. MAID is when you choose your date, have your family with you, and you're all still part of all the conversations up until you say goodbye. I would like to thank Mr. Longpre for his assistance over the last few months and Adam Moore for recommending me. Thank you, and I'm very willing to answer questions.
Thank you very much, Ms. Bayless. Next, we'll go to Diane Riva-Gwartz for 5 minutes.
Thank you for this opportunity to present to your committee. I've been a nurse practitioner for over 20 years and a MAID assessor and provider since June 2018. At the time that I became involved with MAID, there were no community providers in Niagara, where I live and work, and no funding mechanisms for NPs to provide this care. As such, I worked as a MAID practitioner without any financial compensation for almost 3 years until specific funding was established 1 year ago. To date, I have completed 55 MAID assessments and 24 provisions, and I'm an active member of the Canadian Association of MAID Assessors and Providers. In addition, I think it is relevant to this committee that I'm also a family member of a recipient of MAID, as my mother, who had both serious physical health problems and a long-standing mental illness, had an assisted death in August of 2018. I was asked to present today on the implementation of MAID in Canada. I'm going to speak to what I think have been the major successes and challenges, as well as recommendations that I have for moving forward. Firstly, I credit Canada for establishing assisted death as a universal healthcare option for all citizens who meet the eligibility criteria, and for the focus of care being centered on patient needs and desires. In addition, I believe that the changes in legislation with Bill C-7 in March 2021 have improved the process of MAID, specifically with the elimination of the reflection period, the introduction of the waiver of final consent, and the opportunity to access MAID for those whose death is not reasonably foreseeable. As a MAID practitioner, I consider it a privilege to be able to provide this care to those who are suffering intolerably, but it is also the most emotionally challenging work of my nursing career. With increasing numbers of MAID requests and the significant workload demands related to the assessment of patients who do not have a reasonably foreseeable death, the dearth of MAID practitioners is a serious challenge to care provision. With anticipation of the passing of legislation to allow for mental illness as a sole underlying medical condition, this workload will undoubtedly increase dramatically. Across Canada, there are nurse practitioners who are interested in providing MAID care, but require a funding mechanism in order to do so. This country's network of MAID practitioners is an amazing resource that needs to be protected and expanded to allow for the availability of MAID as an aspect of end-of-life care to all Canadians. Unfortunately, in many communities, institutional policies prevent the provision of MAID to those requesting it. For example, in my community, due to hospital policies and resources, it is difficult to receive MAID in the hospital system. The rehabilitation and hospice both have policies that specifically prohibit the provision of MAID in their centers. It is inequitable and unjust that individual institutions are able to establish policies that deprive those who require their services the opportunity to access an assisted death. The final challenge I'd like to address is the limited awareness, community supports, and access to assisted dying services. There are many communities like my own where the awareness of MAID as an end-of-life option is very limited and not well communicated to patients and families. In addition, support services for MAID are extremely limited. As community providers, we need assistance from the healthcare system for management of referrals, administrative support, and community liaison activities. And lastly, inequitable access to MAID care geographically is a significant challenge in this country. Finally, my recommendations. As I'm sure you are aware, there is significant interest in the concept of advanced requests for assisted dying. This would allow for patients who are preparing for a decline in health status and capacity, example those with dementia or neurological conditions, to specify criteria and/or conditions that would then trigger their MAID request. Currently, patients often feel caught between choosing to have MAID before they are actually ready and missing the opportunity to access MAID due to loss of capacity. The need for enhanced resources for MAID practitioners is already a significant issue. However, with the potential changes as of March of 2023, planning for healthcare resources is critical. Adequate funding to ensure MAID practitioners are able to provide this care, as well as to support training of new practitioners, is fundamental in anticipation of the increased demand and time commitments that the assessment process will require for those with mental illness as their main condition. In addition, a plan is needed to ensure that there will be the necessary psychiatric resources in place to support this work. It is essential that planning to ensure adequate funding and supports occurs prior to the implementation of legislative changes. And lastly, those of us providing MAID care in the community desperately need support. There needs to be increased funding for those who provide MAID in the community, including nurse practitioners, and an organizational infrastructure to support the work that we do. This will ensure that MAID care is available for those who wish to die peacefully in their own homes, at their request, surrounded by those who mean the most to them. I appreciate having had this opportunity to present to your committee and share my thoughts on the implementation of medical assistance in dying in Canada, and look forward to your questions.
Thank you very much. And lastly, Dr. Sonu Gand.
Thank you, Madam Chair, for the chance to speak. My name's Sonu Gand. I'm a professor at the University of Toronto and Chief of Psychiatry at Humber River Hospital, serving a diverse population, including marginalized communities. I'm former president of both the Canadian and Ontario Psychiatric Associations and sat on the Council of Canadian Academy's panel on mental illness. I've worked in psycho-oncology with dying patients and their families throughout my career. I'm speaking as an individual, not representing any group I work with. I'm also physician chair of my hospital's MAID team and not a conscientious objector. I don't bring any particular ideology to the issue other than advocating for evidence. I believe sensitive public policies like this demand a non-ideological, evidence-based approach. I've seen the benefits of MAID in appropriate situations like Mr. Bayless's, and I've also been sensitized to the dangers of MAID in inappropriate ones. I've come to realize our MAID expansion to non-dying disabled and those suffering from sole mental illness is a tale of two cities, two worlds actually. Evidence shows that when death is foreseeable, people seek MAID to preserve dignity and autonomy to avoid a painful death. Those seeking MAID in these situations tend to be, in the researchers' words, white, more educated, and more privileged. That's been used to suggest MAID is safe to expand to other situations. However, when expanded to the non-dying disabled for mental illness, that association completely flips. Then a different group gets MAID, the group of non-dying marginalized who have never had autonomy to live a life with dignity. Rather than death with dignity, they're seeking an escape from life suffering, and they do overlap with those who are suicidal in the traditional sense. Evidence shows this group is more marginalized, has unresolved psychosocial suffering like loneliness and isolation, and a terrifying gender gap emerges of twice as many women as men receiving death to avoid life suffering. Introduced to help avoid painful deaths, MAID expansion provides these marginalized non-dying people death to escape painful lives. Worse, many of these people could have gotten better. CAMH, the Canadian Association for Suicide Prevention, and others have concluded evidence shows we cannot predict irremediability of mental illness in any individual. I can't comment on the Federal Mental Illness Panel's specific recommendations since their report is delayed. Still, the panel cannot manufacture non-existent evidence. That panel was charged with recommending protocols, guidance, and safeguards on how to implement MAID for mental illness, not with reviewing whether that can safely be done. That and the sunset clause is not how science works. No drug company is told their sleeping pill will be approved in 2 years without evidence of effectiveness or safety, while being asked to develop instructions on how to use the pill in the meantime. The sunset clause and the federal panel's mandate is based on less evidence than required for introducing any sleeping pill. In bypassing the primary safeguard against premature death of getting MAID only when we can predict irremediability, any other so-called safeguards can be no more than false reassurances and lip service. Marginalized people in despair who could get better will get MAID. I think it bodes ill that a member of the 12-person panel resigned months ago, though her name remains on the public website. While over 85% of Ontario psychiatrists who responded in a recent survey supported MAID in general, less than 30% agreed with MAID for sole mental illness. And by a 3-to-1 margin, they opposed the sunset clause. The Quebec Commission has now recommended against providing MAID for sole mental illness. Last March in the House, Monsieur Thoreau, you said, if the expert panel and special committee arrive at the conclusion that mental health should be excluded, it will be excluded. The panel's narrow charge would have prevented them even considering excluding mental health. I call on you now to listen to the evidence and honor that commitment through this special committee. You know, I grew up hearing the story of the Komagata Maru about those who were refused entry to Canada and sent back to India, some to their deaths. As a child, it showed me that the same policy, the Continuous Passage Act, could ostensibly be the same for everyone, yet in actuality be racist towards some. I view our current MAID expansion the same way. That's the tale of two worlds, same law, different impacts on different groups. It's a myth that expanded MAID is just about autonomy. The planned expansion and sunset clause may increase privileged autonomy for some to die with dignity, but it will do so by sacrificing other marginalized Canadians to premature deaths for escaping painful lives that society failed to allow them to live with dignity. That's not my Canada, and it should not be yours. Thank you for listening. I'd be happy to answer any questions.
Thank you so much. Thank you to all of our witnesses for your compelling testimonies. We'll begin our first round with Madame Vien. 5 minutes.
Merci beaucoup.
Thank you very much, Madam Co-Chair. My first question is for Ms. Gwartz, and Ms. Bayliss might be able to chime in and give her input. First, did you hear the testimony of Dr. Félix Pajot from earlier this evening?
Madame Gwartz, est-ce que vous...
Ms. Gwartz, did you hear Mr. Pajot's testimony earlier?
Guys, I was not aware that I was allowed to be in.
Alors, rapidement.
Well, to make a long story short, did you hear Mr. Pajot's testimony? That's my question.
No.
Monsieur Pajot soutient que...
Mr. Pajot contends that an individual who has dementia should not be eligible for MAID when they have made an advanced medical directive. In his opinion, it's unethical because of the context. That individual wouldn't take that decision otherwise. So in his opinion, there's a certain incoherency, and that those two do not go hand in hand. What would be your stance on that, Ms. Courts, please?
It's a difficult question. I don't know all of the safeguards that that would be put into place in order for advance requests to be incorporated into the legislation for MAID. So I believe that in terms of respecting autonomy and trying to minimize suffering, that this is an area that needs to be explored as an option. I have several patients that I have assessed with dementia that are very determined to have medical assistance in dying as their end-of-life option. And as I said in my presentation, sometimes people have to choose timing in order to balance fear for loss of capacity, and opportunity for advance requests would, I believe, help to minimize that struggle.
Thank you very much. you said, and it's clear that you're very open and very serene about the existence of MAID. You intimated that it's important to increase resources and also funding. Are you making that a prerequisite for the legislation to be amended, i.e. that before any changes are made to the law, that there should be additional funding first?
I would suggest that it's a recommendation, not a requirement. MAID practitioners have been doing the work that needs to be done, but it's difficult with the increasing demands. And in order to be able to service Canadians who are making these requests, we will need more resources.
Well, as far as mature minors are concerned, what do you think? How do you perceive that whole issue?
It's quite honestly, it's not one that I have had to deal with or have given a lot of thought to. I do believe that age is, as a cutoff, is a number and can be arbitrary, and there is concern for sure in terms of people having, again, to achieve a certain criteria that may be arbitrary in order to have equitable access to care options. So I believe that it's something that should be explored, but again, would need considerable safeguards to ensure that individual safety is still maintained.
Merci beaucoup.
Thank you very much. I'm sure that I'm running out of time, but Ms. Bayliss, quite obviously...
Madame Vian, time is up. I apologize for interrupting. We'll go next to Monsieur Arsenault.
Merci, Madame la...
Thank you very much, Madam Co-Chair. Is Ms. Bayliss still with us?
Oui, je la vois.
Yes, I can see her. Ms. Bayliss, first I'd like to say congratulations on your career as a nurse, and now you're retiring. You've seen more or less everything over the course of your life. Now you're at a wise age, wise old age, as we like to put it. What about, you've seen a Canada that's offered palliative care since for a long time, and since a short time has offered MAID. I'd like you to comment on the fact that in your course of career, and based on the statistics, about 80% of folks who request MAID are already in palliative care, and who didn't complete their lives under palliative care but under MAID, and about 20% of those folks who request MAID want to reach that point directly after thinking about it at length without going via palliative care. Now, based on your experience as a nurse, how do you see all of that?
Well, I haven't nursed for a number of years because I had 3 careers, but I am a registered nurse. And most of the people that I have been knowledgeable with are 100% behind MAID, because none of us are going to go into a nursing home one way or another. And right now, I still do not qualify to have MAID in Canada, because I'm not got anything serious, really, and medically at the moment, and I don't qualify. So people that want to qualify for MAID don't have that opportunity. So that's why I believe so strongly in pre-planning while you're still competent. Because if I got in an accident tonight, I don't qualify.
Mrs. Bailey, Madame Quartz.
Thank you, Ms. Bayliss. Ms. Quartz, I'd like to ask you a question. I come from a very rural region. Moreover, I think I'm one of the rare elected members, or perhaps the only elected representative from a rural region far from the urban centres. In the beginning of your brief, you said that Niagara, which is a very populous region compared to mine, lacks the resources to provide MAID. Could you please elaborate on that?
Thank you for the question. So much of the limitations here in Niagara actually has to do with health human resources and providers who are willing to do the work. It's not really, it's not currently a funding problem. It was when I first started working. As I said, I provided MAID services for 3 years without any financial compensation. And that was because I believe very strongly that MAID should be an option for people in my community. And it wasn't, because we had no providers who could get compensation that were willing to do the work. So the current model in Ontario provides funding for physicians to be able to bill through OHIP, but there is no model for nurse practitioners in the community who are competent to be able to provide this care to be able to get compensated. So that was a major issue. And then...
And is that the case also today?
So a year ago, myself and a colleague led a very strong advocacy program in order to be able to have funding allocated specifically for us here in Niagara. So we do now have funding, but it's just us. It's not throughout the province.
Northern Ontario, for example, they don't have that access or that resource.
Correct.
Wow. Est-ce que vous avez besoin en tant que...
As a nurse, do you require training in Niagara or the region of Niagara to be able to offer MAID?
So I am a nurse practitioner, and nurse practitioners are qualified to be able to provide MAID. Any MAID practitioner wants to do training for sure, and there are programs that are actually in process now being developed, as I understand. When I trained 4 years ago, it was a self-directed training program, and I had a mentor that I worked with and did a lot of self-study. So yes, there was training.
Thank you very much. I'm running out of time, I imagine, Madam Co-Chair.
Yes, there's 5 seconds.
Merci beaucoup.
Thank you very much.
Third last, there's Monsieur Thériault for 5 minutes.
Merci beaucoup, Madame la...
Thank you very much, Madam Co-Chair. Well, I'd like to direct my question to Ms. Bayliss first and begin by saying that her testimony really touched me. I don't think that there's anything more beautiful to wish another human being than the ability to be surrounded by their loved ones and to feel in that instant serene on the threshold of death, surrounded by one's loved ones. It really touched me, and I really like to thank you for sharing that intimate moment with us. Now, I would like to ask you a question. You've had incredible experience in terms of healthcare and as a nurse and as a person. Has that in some ways led you to a better understanding of the importance of advanced medical directives and advanced planning? And just a caveat, if I may, you talked about putting in place a process when one writes a will. Does that all that need to be notarized, in your opinion?
Yes. I would recommend that a document be made both medically and legally and through the Parliament, something that all parties agree on and legal, and across Canada comply with it.
Merci.
Thank you, Ms. Gwartz. You spoke about accessibility issues, namely MAID versus palliative care, in your opinion, there's still a lot of trouble. On the one hand, making palliative care fully available without excluding the whole component of MAID. So what you're saying is if you have access to palliative care, you don't necessarily have access or the option of having MAID in a palliative care environment or context. Did I understand you correctly?
Yes, in some institutions for certain, and actually I think in some communities as well. I can speak mostly to my own community where palliative care is quite available. I believe people get very high quality palliative care here, but are not always offered the opportunity to be aware of or make choices related to MAID.
Donc, en quelque part, c'est comme
So basically this whole argument of the slippery slope that we were so afraid of by expanding MAID to the terminal phase of life isn't in fact panning out as one would have thought. The providers of palliative care and the institutions of palliative care don't always provide the option of MAID as part and parcel of their palliative care services. And in some respects, I feel that that isn't something that we would have considered to be possible, given that palliative care was the only option for over 50 years. Quite clearly, how can we address this issue do you think, of this exclusion, as it were?
Well, I think a start would be to look at how it is that institutions are able to establish these policies. As I understand, in Prince Edward Island, they've actually passed legislation that prohibits institutions from preventing MAID being allowed in their organizations. I think that there's also, as I did hear a bit of the previous presenters and Dr. Hertz, there's a lot of disconnect. And I think that MAID is not necessarily palliative. It's not part of palliative care. MAID is a different part of health care or medical care, but it is part of end-of-life care. It's an end-of-life option, and it needs to be seen that way. And it's unfortunate that there's, as I said, a disconnect or disharmony between some palliative care practitioners and the practice of MAID.
Well, it's a big problem, obviously.
Yes, thank you. And next, Mr. McGregor for 5 minutes.
Great. Thank you so much, Madam Co-Chair. Ms. Bayliss, I'd also like to echo my colleague, Mr. Thériault's words. Thank you for sharing that very personal story with this committee on your husband's passing and the journey he took in exercising his wishes and how he wanted to leave this world being surrounded by the love of his life and his family. And, reading the document that you've provided our committee, you say, and I quote, "I strongly believe that my rights as a Canadian citizen are being violated as I do not have the opportunity to currently pre-plan my end of life." And you want to see that medical and legal protocol completed so that any and all outside interference, whether they be political, religious, or special interest groups, are removed so that really it is the agency of the individual that shines through. I guess, Ms. Bayliss, we, in a previous panel, the first hour that we had, we did have a physician who was talking about, if someone were to sign an advance directive, what would happen if many years from the signing of that advance directive, if their future self lost capacity but also had a change of heart? Have you ever wondered about that, Ms. Bayliss? Like if you were to sign an advance directive that was perfectly legal in Canada, Like, have you ever been personally concerned that you may change your mind in the future, but lose the capacity to express that change of mind?
Well, I believe that would be part of what the medical and legal people would come up with. That would be all built in, just like you can change your will at any time. So you should be able to change your mind at any time. So I think it would be all part of that protocol lined up and passed through Parliament.
And we've also heard testimony that,
I listened to the whole night, so I heard all the contestants.
Okay, you did. So what did you think when you heard the testimony that, some physicians have expressed that there is a stigma attached to ageism, a stigma attached to the way we care for our elderly, a fear of growing old, a fear of decay, losing your capacity. Did you have any thoughts from your own personal views on what you heard earlier during?
Well, some of it I agreed. Like everybody, we have to respect everybody's views, and this is where the problem comes in, because how many millions of people are, and we all have different views. So we have to somehow come up with something that can come up in the middle and we can all agree on.
And we also heard from palliative care physicians, one of whom stressed that they are there to provide medically assisted life, and that they would make sure that patients have the full understanding of all options available to them to carry that life through to its natural end. What's your opinion of someone who through their own free will enters palliative care, but then maybe during it decides that this course of care is no longer for me, and I wish to now access medical assistance in dying? Do you think that physicians who work in the palliative care world should sort of have some kind of a transition plan, or be asked to respect their patients' wishes? Do you have any views on that?
I believe strongly that they should respect the patient's wishes. And unfortunately, that's very difficult with a lot of doctors. Some of them will not talk about MAID, period. And I think that's wrong.
Okay. Well, I want to once again thank you for providing your testimony to our committee today. And Madam Co-Chair, I'll cease my questions there. Thank you.
Thank you.
Thank you. And I will turn this over to my co-chair, Mr. Garneau.
Thank you, Senator. We'll now proceed with questions from the senators, once again starting with Senator Meji for 3 minutes.
Thank you very much, Mr. Chairperson. My question is directed at Ms. Gwartz. Ms. Gwartz, you assisted your mother who benefited from MAID, and if I understood correctly, that experience led you to embrace the practice. So could you please speak to the process that you follow with your patients, the very rigorous process that you engage in with your patients, those who are requesting MAID?
So just to clarify, I was already working within the field of MAID before my mother had her assisted death. But yes, I did support her through that. I'm not quite sure what you mean by the rigorous process, but I can... I think you're asking kind of what are the steps that are involved in assessing someone for MAID? Okay.
Exactly.
Okay. So when someone makes a request for MAID, it can be done in an informal way, or often through, in Ontario, we have a central kind of intake, and that's how we get the referrals. I contact them directly by phone and set up an appointment to come to their home. At that point, I ask for consent to be able to check their medical records through the online hospital system, so I can get some background information. So by the time I come to their home, I already have some information about what their health experience is. When I get to their home, I have kind of 3 agenda items that I usually try to follow. The first is that I explain the entire process of being approved for MAID, as well as what the actual procedure involves. The second is that I explain what happens in the actual MAID procedure, so they have an understanding of kind of what it looks like. And the third is I offer them the opportunity to begin the assessment process formally, where I complete my initial part of the assessment, understanding from them their personal experience of their journey, their symptoms, what's causing their suffering, and what treatments they may have had, what they've been offered, what they have experienced as changes in their life as a result of their illness. And that visit is usually between about an hour and a half. So I get to know them fairly well, and they get to know me as well. And depending on what the results of that are, we have a discussion about timing. And sometimes it's just information they want to have at that time. Sometimes they're ready to move forward. At that point, they would, if they haven't already completed the written request, they would do that, and we would arrange for a second assessor to come in to do the confirmatory assessment.
Merci.
Thank you very much. Senator Kutcher, you have 3 minutes.
Thank you, Mr. Chair. My questions, I have 3 questions, should be short, for Ms. Gwartz. And I'm hoping that you can help us learn more about a MAID assessment through these questions and on how data is collected. As a MAID provider, say you're seeing a cancer patient and you're not certain at any point in your assessment, would you seek assistance from a colleague, or would you just come to conclusions on your own about what you should do?
So there's multiple ways of gathering information. As I said, I usually have access to health records through the hospital system. I would often contact care providers that they are already seeing, so family doctor or specialists. And if I continue to be uncertain about things, then I may speak to colleagues who perhaps have more experience with the health issues that person has, or possibly the MAID eligibility criteria and how that would play out in that particular situation. We do have, through the Canadian Association of MAID Assessors and Providers, we have a very robust forum that is a confidential opportunity for us to share, and I post on that quite frequently about situations to get feedback from others.
Fair to say that your assessment is thorough, and it's not just a fly-by-night, and you take a lot of time and sort things out very, very carefully.
Most often it's hours. Yeah, sometimes it's months. I had one patient that I was spending a fair amount of time, probably 5 to 10 hours a week on his assessment and supporting him through his journey for almost 3 months.
So these things are not done lightly.
Absolutely not.
Earlier today, we were told that the Ministry of Health MAID data cannot be trusted because it's filled out by a MAID provider. Do you agree that you cannot be trusted to provide correct information about your MAID patients?
Of course, I do not agree with that. We are health professionals. We take all our data collection very seriously and responsibly.
Thank you very much.
Thank you, Senator. We'll now go, on va au sénateur Dalphond.
Senator Dalphond, the floor is yours. Thank you very much, Mr. Co-Chair. My question is for Professor Gand. Now, I understand that you're an opponent to MAID being offered to those who have as their sole purpose a mental health issue, and that they have no comorbidity with any other illness. It's their sole illness, and you've stated that there is nothing that would justify this. Now, you're an expert in this matter who's studied the issue in the Netherlands and in Belgium, where MAID is available for solely on the basis of mental health issues, and there are studies and commissions that indicate that there is a problem when less in the Netherlands, there's fewer than 1% of cases of euthanasia, and in Belgium, 21 cases out of over 2,000 cases. What do you say to that?
Thank you for the question, Senator. I should clarify, my concern is that offering MAID for sole mental illness cannot be done honestly under our current framework. The whole premise of what our MAID framework has been based on and what the Canadian public has been told is that MAID is being offered for an irremediable, in other words, a predictable, irremediable condition. And that fundamentally cannot be met for mental illnesses. When that can't be met, everything else falls apart. And in terms of the Benelux data and the European data you're speaking of, I will point out that year on year, the psychiatric euthanasia there is seeing regular increases quite significantly. I will also point out that
it's not exact. In Belgium, it went down in 2019.
In 2019, so the latest data, you're right. I'm looking at the Netherlands data. But what I will point out as well is the risk to the marginalized that clearly shows. Because when you have a 50-50 gender balance here for MAID when it's for reasonably foreseeable death up until now, and you expand it to psychiatric euthanasia and you find a 2-to-1 gender imbalance, that imbalance parallels the number of suicide attempts that we find women have with mental illness. And most do not try again. Most do not end their lives by suicide. So the concern obviously is converting a transient suicidality into a permanent death. And in that sense, I think that the expansion ends up feeding into sexism, ageism, ableism, and even racism of marginalized populations, because they are shown to have greater unresolved psychosocial suffering. We have to think about how these policies affect all of our Canadian citizens, not just the ones who will get increased autonomy.
Merci.
Thank you. My question goes to Audrey Bayless, if we could start there. You talk about being denied your right to choose this in advance. And we've talked about this kind of the catch-22 that goes along with dementia or Alzheimer's, that you can't ask in advance, and then once you're diagnosed, it's hard to ask after the fact. How are you dealing with this? Have you talked to other medical professionals? Are you doing a list of things that you think would constitute for you intolerable suffering and a situation in which you would like to access MAID? How are you preparing for this, even though you don't have the right yet to do this?
Well, I'm 84 years of age, and I feel I've had a very good life. And I have it very clearly stated in my document for them to take me somewhere that, well, I could qualify. I know people went to Switzerland. When they can make a decision. If I can't make it, I have no intentions of going into a nursing home. So I will do whatever is necessary. I think about it an awful lot, and my friends are in the same situation as I am. We're all getting up there in years, and what's our option if you don't want to go to a nursing home? There's only one way out. I can't understand why people can't talk about death these days. It seems to be a taboo subject, and we're all going to die. Mm-hmm. So to me, it's very personal, and I have the steps in place for me if I get so I can't look after myself.
So your friends and your family are very aware of this, and if you have to go to another country, you will.
Oh, definitely. My passport's always valid. There's money in the bank to take my whole family over there, and they can party and do what they want. They got to wait to bring my ashes back. If they don't want to bring back, throw them out to the fish.
Ms. Gwartz, just to you on this topic, the frustration we've heard in not just this session, but other sessions about people who have taken the ultimate step because they're afraid they won't be cognizant, they won't be allowed to make the decision. They actually take their lives much earlier than is necessary because they have the same fears as Audrey has just expressed.
Are you asking me if I'm familiar with this?
Yes. Yeah.
I haven't had any patients, luckily, who have done that, but yes, I have certainly heard of situations that's happened, and I've actually had patients who have told me that that was their plan. Because we do ask, what will you do if you're not found eligible? And I think it's a difficult situation for patients. That's not a choice they want to make, but they often feel that they want to have the autonomy to choose how they want to live and how they want to die or when they want to die.
Thank
What
you.
about this?
Thank you, Senator
Out of time.
Walden.
Thank you.
We'll go to Senator Martin.
Thank you, Co-Chair. I will ask my questions to Dr. Sonu Gand, and I'll just ask them together if you wouldn't mind answering them both. MAID in Canada is supposed to be for irremediable conditions. My question is, could someone seeking and qualifying for MAID for sole mental illness regain the will to live? That's my first question. And secondly, you wrote an article called The Next National Apology. Could you explain why you've characterized C7 MAID regime as something that will require a future national apology? Thank you.
Thank you for both your questions. I'll answer them in the order that you presented them. The issue of whether somebody could regain the will to live if they are qualifying for MAID for mental illness, the AMPQ, the Quebec Association, wrote a paper is supportive of expanding MAID for mental illness. One of the key authors was actually the chair of the current federal panel. And despite supporting MAID for mental illness, even in their position paper, they acknowledge, and I quote, "It is possible that a person who has recourse to MAID, regardless of his condition, could have regained the desire to live at some point in the future." They then suggest that assessors will have to answer this ethical question each and every time they evaluate a request. My point is that our law does not say grievous and irremediable conditions are determined by an ethical decision. It should be a scientific decision. And on that, there is no question we cannot make those predictions in mental illness. CAMH and every other group that has looked at this, including, frankly, the AMPQ, has said that. So in terms of the national apology piece, this was a piece I think you're referring to that I wrote in the conversation. And in terms of that, when you link all of this together, if we're not providing MAID for an irremediable condition, one we can predict in a person to be irremediable, then what are we providing it for? And what we find we are providing it for is all sorts of other life suffering that is highly conflated with mental illness. So we are exposing our marginalized, vulnerable people who actually could get better. We are providing them false, in my opinion, unscientific assessments, claiming that they may have irremediability when no one can actually make that determination. And based on that, these marginalized individuals would receive MAID. And to me, that's something I think our country would need to issue an apology for at some point in the future.
Thank you, Mr. Chair.
Thank you very much. And at this point, I'd like to thank all three witnesses for their testimony tonight and for answering our questions. Your contribution plays an important part in a very difficult and very important topic that Parliament is looking at. So thank you very much, and especially late at night as well. So thank you for your willingness to come and join us. Thank you. Committee members, there's just a couple of very quick things that we need to look at, and it shouldn't take more than 5 minutes, hopefully. So I'll put it in front of you right now. One is we agreed that written briefs would have to be in by the 9th of May and that they should not exceed 1,000 words. And to communicate that, it will be put into on the AMAD website in a number of places. Now, if you wanted to go beyond that and actually put out a news release, that's something that requires a motion by the committee. Is there a desire to put that out, or are you satisfied that if we advertise it on the AMAD website that will be sufficient? I don't see anybody raising their hand, so it's just something to take into consideration.
Sufficient. I mean, those people who are interested will be following along. Certainly in the email I'm getting from people asking to participate, they already know that website exists.
I suspect you're right. The second point is, this is just by way of information, because there was some discussion about whether the committee might request an extension. I think it's premature to do it at this point, but if it is done, just to let you know that based on precedent of the House of Commons, the report would have to summarize the work done by the committee and recommend that the committee be permitted to continue its deliberations past June 23rd and be granted an extension of X number of sitting days to present its final report. I would suggest it's a little premature for us to make that decision at this point. We still have a number of meetings, but it is something that you may want to hold in the back of your mind. La troisième chose, c'est que...
Third item. We're going to meet this Thursday evening. You're perhaps already aware of that, for a period of 2 hours. We got confirmation that time slate was available from 6:30 to 8:30 p.m. on Thursday night, and we'll be able to proceed with our work.
Palliative care, as you know. So just to let you know, we're going to be busy on this committee. There's no question about it, as you all have noticed. A question for you. Palliative care, Thursday night, 2 hours. The next meeting is next Monday after that, a week from today. Do you want to reserve the 3 hours for palliative care, or is there a feeling that 2 hours will do it on that subject and we can move on to the next subject, which is advanced requests or advanced directives? Does anybody have anything they would like to? Yeah.
After this Thursday.
Thursday is palliative, but do you want a second full session on palliative, or are you ready to move on to advanced directives? So, okay. Senator Walden, your hand is up.
Yeah, I'm wondering if it's just not specifically on that question, but if there's the possibility of getting some kind of a work plan. Yes, I think we all appreciate how busy this committee is going to be, but we all have other committees as well. And we kind of run on the MP schedule because you have votes and whatnot, but we have our own schedule of committees and work and commitments in our chamber too. So is there some intention that you will actually map out, so that if a Thursday comes up, we need to be able to plan for that?
So we live in an imperfect world, Senator, and at the moment the plan is 2 sessions per subject at the moment. But if we find as we go through them that we say, well, we need a little bit more, we'll have to cross that bridge when we get to it. We haven't got a whole bunch of sessions ahead of us, but at the moment the planning is 2 per subject. But what I was bringing up tonight was a way of perhaps fine-tuning it a little bit if people thought maybe in the case of palliative, 1 session might be enough. And the other thing, of course, is that we don't know when those Thursday nights will be liberated. We'll do 4.
Yeah, that's more my question.
Yeah, we're going to have to play that one by ear because the BOIE is not going to give us advance notice a long time ahead of time. So we have to be a little bit nimble on this. A work plan would be very nice, but it's not going to be. I can't give you anything better at this moment than do you want to have 2 sessions per per subject matter, and we can fine-tune as we go along. As I was suggesting tonight, something that maybe you want to consider, or do you want to keep next Monday night also for palliative? Go ahead.
I'm trying to go to advance directives. I'm raising the other issue, which is, the maximum notice that we can get. I mean, if you only just discovered that we were meeting next Thursday or this Thursday night, if you only just discovered that, but as quickly as we can be informed of that as a membership, it would be really helpful. So that was.
Believe me, we are trying to do that. We're doing it. We're doing this in real time, all the time. Monsieur Arsenault.
Personally, next week, well, I'd do Thursday on palliative care, but next week I'd move on to another topic. That would be my preference.
Mr. Maloney?
I was going to say exactly the same thing that Mr. Arsenault said. Tonight we essentially dealt with palliative care.
Senator Kutcher.
Thank you very much, Mr. Chair. And first of all, I'd like to thank you for raising the potential for an interim or not a complete report, and something that we can think about as we go forward, because I think that this is such an important topic. To be rushing it would not be fair to the people that are waiting for this report.
Understood.
The second thing is on palliative care. Would the witnesses that we are going to hear be able to resolve a conundrum that came out of the discussion that we heard today? There were some people saying that funding for palliative care has gone down. Other people were saying funding for palliative care hasn't gone down. In fact, more people are getting palliative care. That it's hard for me to square that circle. I don't know the answer to that. We really need to know the answer to that. That's a very fundamental point. Do the witnesses that we're going to hear next time have that information, or something the Library of Parliament could provide for us if we ask them for it? I just don't know enough about how this should work.
Well, we did hear different opinions. You're right, but I don't know if the witnesses. I can't predict whether they will shine the proper light on it or not. But if it continues to be sort of two camps, if it continues to be, perhaps we could ask for some help from the analysts or
right, because this sounds to me like it's fairly factual. I mean, one could actually get data province by territory and actually look at where the budget lines have happened, how many people have received palliative care over the time, et cetera. I mean, that should be possible.
Well, hopefully the witnesses, we will hopefully get 6 witnesses this Thursday, and perhaps they will all lean in the same direction and give you a better sense of who's right. That's part of the job. People have different opinions, unfortunately, and I know it's factual, as you say, but perhaps we'll uncover that.
Opinions, but...
Yes, but not to our
different issue.
Y avait-tu quelqu'un là?
Someone else want to say something?
Okay, I'll start in the top left corner. Mr. Barrett.
Thank you, Mr. Co-Chair. So just with respect to Senator Wallin's discussion about a work plan, I wonder if that wouldn't be prudent to produce as soon as possible. And the reason is, when we discussed the analysts, the amount of time that they needed to be able to produce reports of certain lengths, we were expecting to have 4 3-hour meetings. And now there are discussions to add as many as 12 hours to the week of May the 22nd. And so I wonder what the impact that would have on the analyst's ability to produce a report of 10 pages or larger. And further, just with respect to the conversation about how many meetings we're having on each subject, I would say the questions of palliative care have not been resolved, and just to look back, Senator Kutcher just had further question on the subject. I think there's more to hear there, but certainly if we're potentially adding an additional 12 hours of meetings, I wouldn't want to prematurely move on to another issue or another sub issue, as it were. So I do believe that a work plan, something that we can discuss, or that the subcommittee could convene and discuss. Or at least to sidebar about before we come back to a full meeting. Thank you.
Thank you. And so on the question of whether next Monday we should stay on the same subject, I think you're leaning in that direction of a second session on palliative. With respect to the work plan, there's a couple of issues we're working at the moment, and that I think we're going to have to get together as a subcommittee. The first is, and this has an influence on the analyst's work, is how big a document that we want to produce at the end of this. There's a big difference between 10,000 pages and 20,000 pages. And that's something that we need to decide, because that has an influence on how much time they need at the back end of this to prepare that report. And then another factor is the translation. And the translation services at the moment are probably the most, the commodity most in demand at the moment. And that also can back us up as well. So that's why it's at the moment we haven't quite nailed down a firm, predictable work plan, because we're having to deal with that. And I will be asking the subcommittee to talk about this, because we need to figure that out. Then we may be in a better position to put together that work plan that you're looking at. But please bear with us as we try to answer a couple of questions before that, so that we're in a better position to put out that work plan.
That's very helpful. Thank you, Mr. Co-Chair.
Ms. Fry, you're on mute, Ms. Fry.
I just wanted to suggest that the issue of palliative care is not actually resolved. However, I think Senator Kutcher made a very good point when he said that questions of whether palliative care services are going down, that would be in different provinces. This is not a federal thing. Palliative care services would be going down. It would be a provincial thing. So the question is, that's factual data we can get. If palliative care services are going down, we can get that data. If palliative care services are going down and being replaced by MAID services, that's something we can also get the Library of Parliament to research for us, because we only have not very many meetings coming up, and we still have not touched on the very difficult and thorny issues of mental health, mental illness as a single issue. We have not discussed minors, we have not discussed, we need to get our teeth into that, because those are really complex issues. I think the palliative care issues are clear and factual, but these others are really cognitive issues, complex issues that we need to get to the bottom of. So I just think we should move on to something else at the next meeting. Get information on palliative care. We can come back to it when we get the information from the Library of Parliament.
Thank you. We agreed that we would go with palliative as our first area of study. Now, perhaps we can put in a request to the Library of Parliament to dig up the information that Senator Kutcher is asking for, but I think that we should go with palliative for this Thursday. I don't think we should bring everything to a grinding halt on that at this particular point. But your point about getting some assistance from the Library of Parliament, perhaps to answer the questions, is a good one. Yeah. To my fellow co-chair, Senator Martin.
Thank you, Mr. Co-Chair. I wanted to just say, in regards to Senator Wallin's question about Thursday, because it was happening in real time, I didn't get a chance to communicate with all the senators, but I'm going to make it a top priority to ensure that information is shared more quickly. And so that's, I just wanted to let Senator Wallin and my colleagues know. And regarding palliative care, it's a very important issue. It's very complex. Beyond getting some of the numbers, I do think that we need to hear more about it, in that a review of palliative care should have been done, and we didn't have a chance to assess the lay of the land, especially how it intersects with MAID. So I would strongly recommend that we keep 2 sessions per topic. They're all complex, in my opinion. Thank you.
Thank you, Senator. Sénatrice Mégy, vous...
Senator Meji, you raised your hand, I believe. I'm sorry I didn't see you earlier. You've got your answer already, I understand. Colleagues, thank you. Anyone else would like to chime in?
Mr. Ananda.
Thank you, Mr. Chair. So with respect to a subcommittee meeting, is it possible to schedule one this week outside of the schedule for MAID? I think we need about an hour if we can hammer out some of the outstanding issues that we discussed at the subcommittee last Wednesday. And that would resolve, I think, a lot of the discussions we're having today with respect to palliative care. At this point, if we do a 2-hour session on Thursday on palliative care, and I believe a number of witnesses today spoke on that issue today. So, we can probably do a 2-hour session on next Monday, May the 2nd, and then have the last hour for some other item we can move on to.
Okay, thank you. When we can have a subcommittee meeting, we need to have one because this is certainly something we need to deal with. I can't answer your question, but we'll get back as quickly as we can. Mr. Thériault?
Mr. Thériault. Well, Mr. Chairperson, I know we're going to meet on Thursday. That's a good thing. The Board of Internal Economy won't be sitting, so we'll have that opportunity, and we don't know if next work whether the Board of Internal Economy will sit or not. But before we meet as a subcommittee to deal with a situation that we aren't sure of at this stage of the game, I prefer that the subcommittee meet after Thursday's meeting, potentially, at least not before Thursday, because right now we don't have the information we need to flesh out a work plan. What we have agreed to is that for the time being, there'll be no extension. The work plan will go through to the 23rd of June as a so-called deadline, which is a bit unrealistic in my opinion, but we've already hashed over that issue. Now, we do know that in the constituency week, there'll be 4 additional 3-hour meetings that will take place. Now, we know all of that, but let's wait and see how many Board of Internal Economy time slots we'll have before we flesh out the work plan, and then we'll have the meeting on palliative care on Thursday, and after that meeting, if we don't have any other information, we'll determine whether we proceed on that theme or if we move forward to the advanced directives or advanced requests. But I think the week's already pretty full, as far as I'm concerned, at least. Thank you very much, Mr. Thériault. The only challenge we face in that regard is that if we decide on Friday that we don't need a meeting on palliative care on Monday and that we're going to move on to something else, well, it's too late to call in the witnesses. So that's why we've expressed this preference. Now, I've heard from members who'd like to have a second meeting. Others believe that one meeting is sufficient. But I think that we should err on the side of caution and plan at least for a second meeting. Mr. Senator Dalphond, go ahead. Thank you very much, Mr. Co-Chair. Just a parenthesis. I get the sense that we're trying to move forward hastily. Now, it's tough to move forward without having the documents from the witnesses that have appeared before us. A number of witnesses have referred to what is contained in their briefs that we haven't even laid eyes on yet. So I would have liked to have asked questions based on their briefs and not just a summary of their briefs. And then when I do see their briefs, well, it's too late. Now, regardless of the themes and the order in which we proceed, I think we need to receive the written documents before we hear from the witnesses. And if there are some ready, that already translated in view of next week, I'd like to at least read their briefs. It's very rare that I take a position on something without having read what the person's stance is on a particular issue. Response, well, it's really logical what you've just laid out. But the problem is that we can't demand that they provide us the briefs in both official languages. When they appear, they can send us something. If they send a brief, or it's usually in one language and it has to be translated before it's sent out to you. And we just can't proceed unless it's bilingual. It's inconvenient, but unfortunately, that will draw things out if we proceed as you've requested. Remember that we just reached out to the witnesses a couple of days ago so as not to waste too much time. And they're not able to provide their briefs in both official languages. That's understandable, that they can't do that in advance. And in some cases, they're not obligated to send their brief in. They can send it after the fact if they wish.
But I think for the moment, there's three things that come out of this. We should ask the library to do a little bit of research on the questions with respect to palliative care that you raised, Senator Couture. We will try to have a subcommittee. I can't tell you exactly when to discuss something towards having a work plan, but that will be based on us making decisions about the size of the document and those kinds of things. And then the third thing, I think for the moment, given that there's very different points of view, I would suggest that we plan on palliative care both this Thursday and next Monday night. Is that something that you can agree with for the moment?
Oh, no.
Oh,
Hands up,
okay.
please. Thank you.
Just a moment, Hetty. Our analyst, Hetty Fry, Marlisa had her hand up first, so go ahead.
Okay, sorry.
Thank you. I'm really sorry. I'm not trying to complicate issues. Absolutely, we will make a request to look information to see if they can find data relating to provincial spending pre and post MAID with respect to palliative care. It will be, unless somebody has already done that research, it will blankly, so we'll do our best. If the committee wishes to go ahead with an additional meeting on palliative care, the witnesses that had been identified in the work plan have mostly been exhausted, with the exception of those on the Liberal witness list. So I offer that just in case that helps people determine whether or not they need or would like to have another meeting on palliative care. We would need more witnesses from some of the parties to be able to do another full meeting. Thank you.
Okay, so you're saying we don't necessarily have witnesses for next, if we get 6 witnesses this Thursday, we do not have more witnesses to fill up the next session?
We have identified 3 panels of 9 witnesses, but after that, there wouldn't be a balance of perspectives on panels beyond those 3 panels.
Okay, Mr. Cooper?
Thank you, Mr. Co-Chair. And just on that point, we have a number of names that we could provide on our side. So that would not be an issue.
That will not be an issue.
Yeah.
So those would have to be provided very quickly, very quickly. All right, just one moment. And now it's Senator Wallen, but we need you to put your headset back on. And Hetty, you can do yours too while you're waiting. Go ahead, Senator Wallen.
Yeah, I will do that. I think you can hear me there. On this, because the witnesses, because we've run through the list of witnesses, I think that we should maybe move on. We can always come back to palliative care if the data suggests there's something there that we need to really drill down on. I agree with Hetty on this one, with, that we really need to move on to other issues. Our time has been so crunched because this committee was not convened, and now we're trying to cram and meet all hours of the night and day. I mean, there were comments made that we'd agreed to do this and we'd agreed to do that, which I'm not informed about, and which, as I say, our schedule is very different. We travel at different times. Some of us go to places it's difficult to get to. So I'd like to make sure that we, at the very least, hit all of the major topics in the time we've got allotted in case extra days don't come up or in case some of us can't participate. And then maybe sooner than later have that conversation about either asking for, more time so that we might be presenting an interim report, because this schedule is nothing short of insane for topics that are so fundamental. So that's what really concerns me. Thank you.
Okay, thank you, Senator Wallen. Ms. Fry?
Thank you. This is a mutual admiration society. I agree with Senator Wallen, because whatever information we're going to get about palliative care from the data gathering that we're going to get, it's going to mean we're going to have to discuss it when we get it anyway. Whereas as we move on to different aspects of this study, we might find us wanting more information on certain things. So if we can start off, do all the pieces, look for the information, get them coming back to us so we can discuss them, that would make far more sense to me than listening to people tell us about palliative care next meeting and finding out that they still haven't answered our problems, our issues, and our questions. It just doesn't make logical sense for us to do it this way. I think we should get the information we need first, and then go back to palliative care.
Well, thank you, Ms. Fry. Do I see anybody else? Sénatrice, allez-y.
Senator, Mr. Chair, can we vote on this? 1 meeting, 2 meeting? Yes, that is possible.
Okay, so let me just frame one thing here. We're trying to move forward and use our time as productively as possible. It's, as a work plan, we have to be ready to adjust as we go along, but we need to move forward on this and use our time as wisely as possible. So Senator Mejia has suggested we should take a vote on whether next Monday we move on to another topic or whether we devote the second 2 meetings, the second meeting to palliative care. So I'm going to ask for a show of hands here for those who are here. Those who would like to do palliative care this Thursday but move on to something next week, please show your hands. 1, 2, 3, 4, 5, 6, 7. Keep the hands up on the screen. 8. 9. Okay, that looks like a majority, but so that was very clearly to do just palliative care this Thursday and move on to. It would be advanced requests or directives starting next Monday. As a committee, you can choose to come back to something later on, but for our purposes now, I think there's a majority who want to do palliative this Thursday and advanced directives next Monday. Okay. Anything else? Thank you. This meeting is adjourned.